What's up, Ninja Nerds? In this video today, we are going to be talking about obstructive lung diseases, and there is so much to cover in this one. It is going to be a monster, but it's probably going to be one of the most important ones that we'll talk about in the pulmonary or respiratory system. So when we talk about obstructive lung disease, we're going to go through specifically talking about the types, the causes, and the pathophysiology of obstructive lung diseases. Now, there's three particular types of obstructive lung diseases that we'll talk about. One is COPD, the second is asthma, and the last one that we'll talk about is bronchiectasis, which one of the common causes that you guys may be tested on in the exam is cystic fibrosis. So we'll talk about all of those. Again, their particular causes, the pathophysiology, because the pathophys is extremely important to the clinical features, the complications, and even the treatment processes. All right, so first thing, when we talk about COPD, what I want you guys to understand is COPD, chronic obstructive pulmonary disease, is really two disorders in one. And those two disorders is chronic bronchitis and emphysema. Now, the way that we differentiate these is kind of based upon a small definition. So chronic bronchitis is a type of chronic obstructive pulmonary disease where they have lots of productive cough. They have lots of mucus within their airways. And whenever they're coughing and coughing and coughing, it's just a very productive cough with lots of that mucus. And when we say whenever that productive cough has been greater than 3 months, so here's what I want you to remember, greater than 3 months for 2+ years, that is somewhat of the definition, diagnostic of chronic bronchitis. Now, the other flavor of COPD is emphysema. Emphysema is more of a structurally defined type of COPD. And what that means is, and we'll go through the pathophys here, is that there is a lot of neutrophilic proteases and elastases that are actually released. And what these molecules do is, so imagine here I have a neutrophil. This neutrophil is going to release very nasty types of what's called elastases. And these elastases, what they're going to do is they're going to cause destruction of some of the elastic tissue within the alveolar walls and the bronchial walls. So imagine here, in this actual kind of like a red color here, imagine that I have some type of elastic tissue. And this elastic tissue is important because not only does it form like septa of the alveolar walls, but it also gives some strength to the actual bronchioles in the alveolar walls and prevents them from collapsing. What happens is I'm going to destroy some of that actual elastic tissue, and I'm going to make the actual alveoli much, much bigger. And I'm going to cause destruction of the septal walls, and I'm going to destroy some of the elastic tissue in the bronchioles. And so the end result is that the bronchioles will collapse, and you'll have these big, large air sacs with a decreased surface area. And this is one of the key features that we'll remember for specifically emphysema. Now, when we talk about COPD, we know chronic bronchitis, emphysema. What's particularly the trigger, the cause for these particular disorders? The most common cause is going to be tobacco smoke. 90% of the time, it's going to be due to some type of tobacco use. In small other cases, it could be due to environmental pollutants, but that's going to be less common. There's also one more cause that we'll talk about when we get into emphysema, specifically something called alpha-1 antitrypsin deficiency. So we'll put down one other particular cause here that I do want you guys to potentially remember here as a trigger or a cause behind COPD. We'll mention it, and this one is called alpha-1 antitrypsin deficiency. So it's called alpha-1 antitrypsin deficiency. And this is specific to emphysema, and we'll talk about that. All right, but how does all of this actually take place? So we have a patient who has COPD, whether it be chronic bronchitis, emphysema. Patients can actually have both of them. So both of them can coexist in one patient who has COPD. They're exposed to tobacco. This could even be secondhand, so it could be them actually smoking, or it could be exposure to it in a secondhand process. Or it could be pollutants, or they could have this specific type of genetic condition. Either way, let's say that they're exposed to this tobacco, this or pollutant situation. How does this trigger the COPD process? So imagine here I'm going to have some type of tobacco smoke. When I inhale it, it gets into the airways. In the airways, you have these special types of immune system cells called alveolar macrophages. And these alveolar macrophages will get picked up by the specific type of trigger, which is all of these that we just talked about over here. So here's our trigger. Could be the actual tobacco smoke. They'll take up, phagocytose some of the actual inhalants. Once they do that, they become stimulated. When they become stimulated, they start releasing lots of cytokines. And some of the cytokines tend to be things like leukotrienes, like leukotriene B4, or interleukin 8, and there's all these other different types of chemokines that it's releasing. And what this does is this really helps to be able to jack up the actual inflammation process. So it really increases the inflammatory process. One of the big things that actually happens as a result of this is that these chemicals can really stimulate very specific immune system cells to come to the area of the lungs, where the actual bronchioles and the alveoli are, and cause these white blood cells to actually move into this area where all of these cytokines and triggers are. And these are called your neutrophils. Now, once the neutrophils come into this actual area, they start releasing a lot of very specific molecules, such as reactive oxygen species or other types of free radicals that you can potentially see. And they also release lots of what's called proteases. So these could be matrix metalloproteinases. These could also be elastases, but they're breaking down tons and tons of different types of proteins. And so what you're going to see is you're going to see these things starting to damage the actual respiratory walls. And what you'll see is you see how we have within this actual, imagine we're zooming in on one of the actual bronchioles. If I zoom in on one of the bronchioles here, you're gonna have an epithelial layer. So here's my epithelial layer. Then underneath it, I'm gonna have like a little basement membrane made up of like proteins and elastic tissue. And then after that, I'm gonna have a smooth muscle layer. What happens is, from all of these inflammatory mediators, they can also act on the smooth muscle and trigger the smooth muscle to undergo bronchoconstriction. Plus the neutrophils will come to this area and release lots of reactive oxygen species, free radicals, proteases. And what that's gonna do is that's gonna start causing destruction of some of the elastic tissue. So here, this is actually going to be elastic tissue. We're gonna destroy some of the elastin. On top of that, we're also going to stimulate these types of mucus-producing cells. We're gonna stimulate these mucus-producing cells. And if we stimulate these mucus-producing cells, we're gonna have them make a ton of mucus. And all of this mucus layering is trying to be a protective barrier, if you will. If I have a lot of mucus that's gonna be trying to barrier between the actual epithelial lining and this trigger, it's supposed to be a protective mechanism, right? But unfortunately, it can clog up the bronchioles. So what I see is trigger stimulates macrophages, causes inflammation. Inflammation can cause bronchospasm. They also can release cytokines that attract in neutrophils. Neutrophils release reactive oxygen species, free radicals, proteases. That's going to cause destruction of the elastic tissue within the bronchial walls. And it's going to stimulate mucus-producing cells to increase the amount of mucus within inside of the airways to act as a protective barrier. But the problem with all of this is this can start leading to a lot of inflammation and destruction of the bronchial walls. And you know what happens is whenever these epithelial cells are constantly exposed to this trigger, this actual tobacco, they start releasing things like transforming growth factor beta. And what this does is this stimulates fibroblasts. And fibroblasts are like, okay, I got to come in there because there's so much destruction and inflammation going on that I'm going to have to start laying down lots of fibrous tissue. And this starts leading to fibrosis because they're going to start increasing the fibrous tissue deposition to help with a lot of this inflammatory process. So the end result out of just one exposure to this particular tobacco smoke consistently causes immune system activation, inflammation leading to bronchoconstriction, so therefore we're going to have lots of bronchospasm because the inflammation is going to actually cause leukotrienes to stimulate these particular types of receptors. Histamines are also released. Lots of molecules that are going to stimulate these types of receptors and cause the bronchial smooth muscle to undergo bronchoconstriction. So there's going to be bronchospasm. The second thing is that lots of this inflammatory mediators cause neutrophils to come to the area, releasing reactive oxygen species, free radicals, proteases, which causes an increase in the mucus production as a protective reflex, but it clogs up the airways subsequently. It also starts destroying some of the elastic tissue within inside of the actual bronchial and alveolar walls. And if that happens, it starts actually losing some of the actual elastic tissue within the bronchi and they collapse. On top of that, we destroy some of the alveolar septa and make these big, large alveoli with a really reduced surface area. This process here, where there's lots of proteases destroying the elastic tissue, is very specific to which type of COPD. Which one will we see this more specifically in? Chronic bronchitis or emphysema? Emphysema. So this process is definitely more specific of emphysema as compared to chronic bronchitis. And then the last thing is whenever there's this repeated exposure and damage to the epithelial cells of the airway, they release factors that trigger fibroblasts to come to the area and produce fibrosis. This is leading to irreversible changes of the bronchial airways. And that's one of the big differences between COPD and asthma. Once we start causing lots of fibrosis and chronic inflammation, the damage has already been done and it's relatively irreversible. And that's an important concept to understand. All right, so we have the concept of COPD. We know that there's two types, chronic bronchitis, emphysema. You can have both of these that coexist. We know the differences between these. One, productive cough for greater than 3 months for 2+ years, and one is structural changes due to damage to the actual elastic tissue within the bronchial walls and the alveolar septa causing decreased surface area. We know the triggers is tobacco, pollutants, and there can also be another thing called alpha-1 antitrypsin deficiency. We use the most common cause, tobacco, as the trigger here to activate the immune system, causing lots of cytokines, lots of elastases, free radicals to be released, which leads to what types of effects? Bronchospasm, increased mucus secretions within the airway, destruction of the actual alveolar septa, and bronchioles can start to collapse because they lose their elastic tissue, and fibrosis of the actual bronchial tree. The last thing that I want to talk about here with emphysema is whenever we start destroying some of the actual, specifically here, some of these like connective tissue, the elastic tissue within inside of these actual bronchioles and some of the actual alveolar septa, we start ballooning them up. So imagine here, we actually start ballooning these into these big, large like sacs. So here's this big, large airway sac. What happens is, you may think, oh, this is great for like alveolar surface area, but it's not. When we start destroying some of the alveolar septal walls and we create these large, like big sacs, this actually decreases the total surface area for gas exchange. So we decrease the total surface area for gas exchange, and that actually makes a worse gas exchange process, causing VQ mismatching. But here's the big thing. This big, large sac now that was actually formed due to breaking down the alveolar septal walls is called an acinus. And where these acini form helps us to delineate if the emphysema that's actually present in this patient is due to tobacco use or if it's due to alpha-1 antitrypsin deficiency. So here's what I want you to remember. Whenever you have a bunch of these sacs or acini that are forming in the upper lobes, towards the apex, the upper aspect of the lungs, this is likely due to smoking. Remember, smoke rises. And so in this situation, for centrilobular emphysema, meaning it's affecting more of the top of the lungs, the apex of the lungs. In this situation, it's likely due to tobacco smoking. But if you have a patient who has lots of these acini, and these big acini are forming in the actual lower lobes, the base of the lungs, then this is unlikely due to smoking and it's more likely to be due to alpha-1 antitrypsin deficiency. And this is called pan-acinar emphysema. So pan-acinar emphysema meaning it's affecting the bases of the lungs where they're having lots of alveolar, septal, and bronchial elastic tissue destruction. If it's occurring in the bases of the lungs, it's pan-acinar due to alpha-1 antitrypsin deficiency. If there's alveolar wall, septal, and bronchial elastic tissue destruction causing big acini to form in the tops of the lungs, the apex of the lungs, it's more likely due to tobacco smoking. Let me quickly explain to you what the heck alpha-1 antitrypsin deficiency is and how it causes this. Now remember, I told you that neutrophils will release these things called elastases. And elastases will basically cause the destruction of the alveolar walls. They'll start breaking down this elastic tissue within the bronchioles and within the alveolar septa, okay? And the overall effect here is if I break down the actual elastic tissue within the bronchioles will subsequently do what? They'll collapse. They won't be able to maintain that actual airway open and patent. So they'll collapse. On top of that, they'll form this big acini, which decreases the total surface area and affects gas exchange. Now, elastases are the one responsible. We have a very specific protein that we actually make in our body. And this is called alpha-1 antitrypsin. And what alpha-1 antitrypsin is supposed to do, let's actually do this one in purple here. Imagine here is this cute little enzyme here, and this is called alpha-1 antitrypsin, okay? Here's alpha-1 antitrypsin. What it does is it's supposed to be able to inhibit the elastases. So it's supposed to inhibit the elastases so they don't actually destroy the alveolar walls. But in these patients, due to some type of mutation, they have an absence or deficiency of alpha-1 antitrypsin. And so because of that, if they have less of this enzyme, are they able to inhibit the elastases from causing destruction of the alveolar walls? No. And because of that, you lose the ability to inhibit. So this inhibition that was supposed to be present is gone. And now there is an increased destruction of the alveolar walls. But where does it actually predominantly destroy? Does it destroy the apexes or the bases? The bases of the lungs. So that's important to remember. Plus, patients who have alpha-1 antitrypsin deficiency, not only does it affect the lungs, guess what else it affects? The liver. So one of the other things that I want you guys to remember is if a patient has alpha-1 antitrypsin deficiency and they have the bases of the lungs that have emphysema, you can also suspect that they may have some type of underlying liver disease as well. So think about that in a patient with alpha-1 antitrypsin deficiency as a potential cause of emphysema. All right, we've talked about COPD, my friends. Now let's move on to asthma. All right, let's talk about asthma now. Now with asthma, there's very straightforward causes behind this one. So we already know that COPD is due to some type of tobacco smoke or pollutants, could be alpha-1 antitrypsin deficiency. And we also know that that's usually an irreversible type of reactive airway disease. So there is damage to the airway, lots of inflammation, lots of bronchospasm, and usually there's lots of fibrosis. In asthma, it's also believed to be somewhat of a reversible obstructive airway disease. And the particular triggers, there's a much longer list, unfortunately, but it's straightforward. It's either there's some exposure to an allergen, dust, pet animal dander, pollen, and then think about patients who have other risk factors. And so we call this the atopic triad. So patients who have allergic rhinitis and atopic dermatitis are also at very high risk of developing asthma, what's called allergic asthma. So those are big things to be thinking about. But don't forget the atopic triad. They could ask you that on the exam, saying, what are 3 parts of the atopic triad that put patients at high risk of asthma? Allergic rhinitis, atopic dermatitis, and therefore high risk of allergic type of asthma. Now, the non-allergic causes are also very important. With the most important one that I want you guys to think about here is going to be viral upper respiratory tract infections. This is definitely a very huge trigger for these patients. Again, there's some type of virus that causes inflammation of the airway, and what we'll talk about is that's already a problem for patients with asthma. And asthma, their bronchial smooth muscle, it's just waiting to be irritated. And if you irritate it, boom, it's gonna bronchospasm and cause massive amounts of constriction and bronchial edema. So they're very, very sensitive. The other thing is cold air. If you have exposure to cold air or you're exercising, so you're running outside, again, those particular situations may be enough to be able to cause the bronchial smooth muscle to just get agitated enough and bronchoconstrict. Other things could be GERD. The underlying mechanism isn't completely understood about this, but it could also be a trigger. And the other one that I want you to think about is beta blockers. Remember, beta blockers are important because you know within the actual airway, your bronchial smooth muscle has beta adrenergic receptors, beta 2 adrenergic receptors. And if you stimulate the beta 2 adrenergic receptors, what should they do? It'll bronchodilate. If I give a drug that blocks the beta 2 receptors, will they bronchodilate anymore? No, what will they do? They'll bronchoconstrict. And a patient who has very sensitive bronchial smooth muscle, if you give them that drug, they may bronchoconstrict more intensely than a normal individual. And that's the important thing. So again, don't forget viral upper respiratory tract infection, exercising in cold air, GERD, beta blockers is a big one. And the other thing they may ask you is that a patient here has at high risk for some type of asthma exacerbation. In what particular scenarios? If they have asthma, they also have nasal polyps, lots of nasal polyps, and you give them aspirin, they can develop a massive asthma exacerbation as well. So this is called Samter's triad. So they have aspirin, hypersensitivity, nasal polyps, and asthma. Big things to think about here. So don't forget these 2 triads. Now what I want to do is I want to tell us, now we have exposure to one of these particular triggers, where it's a non-allergic cause or an allergic cause. What would be the early responses in a patient who has asthma, and then what would be the late responses to a patient who has asthma. All right, so the question that you may have is, how do these particular allergens or triggers, whatever it may be, lead to the problematic issues that we see with asthma? And the problematic issues that we see with asthma is that they develop an intense bronchospasm, right? So their bronchioles will constrict, narrowing the airways. On top of that, they may also have a lot of edema and swelling of their airways, which also narrows the actual lumen of the bronchioles. And then later in the disease, their bronchial smooth muscle is so hyper responsive that just a little agitation to it is enough for it to intensely constrict and cause a massive asthma exacerbation. And then again, last but not least, later in the stage, their edema can get really, really bad. And then on top of that, they start secreting a mucus lining that is trying to be a protective response for the actual airway, but again, can cause more obstruction of the airway. So how does all of this happen? So you have the particular trigger here, right? It's within the airways. Once this actual trigger is exposed to a patient who is at risk for asthma, what will happen is it'll get taken up and phagocytosed by what's called dendritic cells within our airway. These dendritic cells will take this and phagocytose this particular antigen and then present it on its actual cell surface on what's called an MHC2 complex. You see that pink protein here that it's expressing it on? This is called a MHC2 protein. It'll express it on that MHC2 complex, the antigen. Then what it'll do is this dendritic cell will expose it on its surface on the MHC2 complex and take it to something called a T helper cell. So here's going to be a T helper cell. This T helper cell will have what's called a T cell receptor that'll recognize that antigen, and then what's called a CD4 protein that'll recognize the MHC2 complex. Once this interacts, it activates these two cells, specifically the T cell. And the T cell will start releasing various different types of cytokines. One of those it may release is what's called interleukin 4, and it also may release something called interleukin 5. Now, when it releases interleukin 4 and interleukin 5, what happens is this specifically will activate another type of cell called plasma cells. And you know plasma cells are basically these antibody-producing factories. When this plasma cell is activated, it'll then release or secrete what's called antibodies. And the very specific type of antibody that it actually releases is called IgE antibodies. Now the IgE antibodies are very important because what they will do is they will come and bind onto a mast cell. So here's going to be what's called a mast cell. And once they bind on with the mast cell, this can activate the mast cell, and also imagine they bind onto the membrane. And let's say here, once it binds onto the membrane, here's again an exposure due to this particular trigger, whether it be an allergen or a non-allergen. It'll bind onto this IgE receptor on the mast cell, activate the mast cell. Guess what this mast cell gonna do? It's gonna get crazy, and it's gonna start releasing massive amounts of leukotrienes, massive amounts of prostaglandins, massive amounts of histamines. And what these are going to do is, this is all going to act on the blood vessels that are supplying the bronchial walls, and it's gonna act on the bronchial smooth muscle, and it may even act on some of the glands. And the result of this is that you're going to vasodilate and increase the capillary permeability. If I vasodilate these little vessels and I increase the capillary permeability, fluid that's in these vessels are gonna start leaking out into the actual bronchial wall. What is that gonna lead to? Bronchial edema. On top of that, some of these cytokines are gonna go here and stimulate the smooth muscle. Here's our smooth muscle layer. And it's gonna activate particular receptors that are gonna cause the bronchial smooth muscle to undergo bronchoconstriction. This will lead to bronchospasm. And this is gonna narrow the airways. Look at all that edema in the airway, it's gonna narrow it. And then the bronchospasm is also gonna narrow the lumen. That's gonna be a difficult time for being able to get air in or out. That's an important concept. All right, so that would be the thing that happens in the early phases. Now, what happens later as patients who deal with this disease, again, let's say that they're exposed to these allergens, right? These allergens, what can happen is the same kind of process here, can get taken up by the dendritic cells. When they're taken up by the dendritic cells will phagocytose them and put them into these things called phagosomes, express them on their MHC2 complex. After they express it on the MHC2 complex, they take it to a T helper cell. The T helper cell will release cytokines. Specifically, one of them may be interleukin 5. Interleukin 5 may activate very specific types of cells. You know, when you release interleukin 5, what it actually does is it activates your bone marrow and says, hey, bone marrow, I need you to make more very specific types of white blood cells. And these types of white blood cells that I want you to make are called eosinophils. And these eosinophils are going to come to the area where all this actual inflammation is occurring. And these eosinophils will release different types of molecules called major basic protein and what's called cationic peptides. And the problem with these particular molecules is that they love to cause tissue destruction and inflammation. So these molecules will come and actually attack and destroy parts of the bronchial smooth muscle wall and cause massive amounts of inflammation. That inflammation that they're going to cause is going to lead to even more intense bronchospasm. Now the bronchial smooth muscle is going to be so sensitive that any particular trigger will cause it to intensely spasm and really narrow the airway. On top of that, we're going to cause the edema to become even worse. and we're gonna really ramp up these mucus glands to try to produce a very thick mucus layer to protect them from these allergens or certain types of triggers by creating a thicker barrier for these things to have to move across to damage the epithelial cells or agitate the epithelial cells. And this is a problematic issue when we talk about this, okay? So now we have an understanding what happens in the early phase of asthma, what happens in the late phase of asthma. We understand the pathophysiology. This is truly important, especially this component of the diagram, because when we talk about treatment, we're going to target very specific steps here. Okay, now let's talk about bronchiectasis. All right, guys, so let's talk about bronchiectasis. Now with bronchiectasis, this is another type of obstructive lung disease, but this one's classified by massive amounts of chronic inflammation, dilation of the actual bronchioles, excessive fibrosis of the bronchioles. And so this is a really interesting type of disorder. With bronchiectasis, we have to understand the primary triggers of the reasons why this happened. And it actually really does make sense. So imagine here I take one of the bronchioles and I zoom in on it and really focus in on it. The reasons why someone would have bronchiectasis is the primary problem is that these patients can't clear mucus. Mucus just builds up within their airways. And that mucus is a problematic thing because it can lead to chronic inflammation. That chronic inflammation can lead to all the things that we'll talk about down here below. Now, what would be the reason why I can't get mucus out of my airways? Well, one of them is think about the structures that are responsible for moving mucus. What are these little guys inside of your airways? Remember, we have what's called pseudostratified ciliated columnar epithelial tissue. That cilia is responsible for beating the actual mucus up so we can spit it out or swallow it, unfortunately, but that's the whole concept. What if the cilia are all jacked up? They're not functioning well. So I have a pack of mucus that's sitting right here. Here's a pack of mucus, and these cilia are naturally supposed to be able to beat this mucus upwards so that we can spit that mucus out or swallow it. If the cilia aren't able to perform that function, such as beating the actual mucus upwards, this does not take place. The mucus won't move. It'll stay in that area, build up. What's a disease that causes a decrease of the ciliary function? You know, there's a disease called primary ciliary dyskinesia. Sometimes we also refer to this as Cardiganer syndrome. And usually what happens in this disease is that they have cilia that are actually not functioning. And on top of that, during the actual development, you know, the heart, the apex is supposed to be shifted 2/3 to the left of the midsternal line. And patients who have this type of disease, Cardiganer syndrome, primary ciliary dyskinesia, their heart can be shifted to the opposite side. So they have dextrocardia, or they may have other organs that were supposed to be on one side switch to the other side. And so we can see something called situs inversus. And so that's another thing to think about who patients who have decreased ciliary function. So they have this bronchiectasis and they have organs switched to the opposite side, situs inversus. Think about that disorder. Another reason is imagine that maybe the cilia are intact, but the mucus that you have here is just so thick. It's really thick, meaning that there is a very little amount of water inside of these bad boys, all right? And there's very little chloride in these bad boys. Chloride is supposed to be able to help to pull water into the secretions, but what if you have a disorder where there's a very special type of transport protein? And this transport protein, which is called it's a cystic fibrosis transmembrane protein, what it's supposed to do is supposed to pump chloride out here and pump water out here. But if this transporter is defective, can you pump the chloride out into these actual secretions and thin them out by yanking water into them? No. And so because of that, the secretions get super thick to the point even if you have normal ciliary function, you can't clear the dang mucus, so it builds up and causes this type of bronchiectasis problem. So think about that. The next thing is, what if I have normal ciliary function, okay? I have thin mucus, no crazy thick mucus, but I have some type of massive foreign body, whether that be a tumor. So here's going to be a massive tumor that's going to be sitting inside of the actual airway. And what's supposed to happen is that this mucus is supposed to be moved upwards. But I have this big foreign body or tumor that's obstructing the actual movement of the mucus out of the airway to be spit out or swallowed. If that's obstructing it, all the mucus that's going to be distal to that tumor or foreign body will build up. And so all of this mucus, just distal to this actual foreign body or tumor, will build up and build up and build up. So think about that in patients who have some type of tumor, whether it be an like luminal tumor or extraluminal tumor. So maybe you have like a lymphoma that's pressing on the bronchus from the outside, compressing it, narrowing the airway, and you can't get the mucus upwards. Or you have a tumor inside of the bronchial airway, which is obstructing it. Or, I don't know, you swallow like a dime or something like that, and it gets stuck in the airway, and it's obstructing the mucus from being able to get upwards. Okay, so those are things to think about. The last one is maybe it's not mucus that's the problem. Maybe the mucus is being produced as a response to a chronic inflammation. There's some type of microbe. You know, one of the big microbes that are worth mentioning here? There's a disease called allergic bronchopulmonary aspergillus. This is a nasty fungal infection. And this microbe can stay here and just cause nasty amounts of inflammation of the airway. That inflammation of the airway, what's a protective response to inflammation? Mucus secretion. And so what will happen is in response to a lot of this actual inflammation, due to this infection, you'll increase your mucus production as a protective response. What if I have a disease that causes like autoimmune attack? And this autoimmune attack occurs to multiple different tissues, including the actual bronchial airways. And this inflammation, as a response to that, what do? They produce mucus. And that increased mucus secretion occurs due to chronic inflammatory states, whether that be locally due to infections, and one of the big ones here is allergic bronchopulmonary aspergillus, or systemic inflammatory diseases such as rheumatoid arthritis or SLE, systemic lupus erythematosus. All right, so this is the concept that I want you guys to understand. So again, when you think about COPD, it's bronchospasm, it's increased mucus secretions. Emphysema predominantly, there's destruction of the alveolar septa, the alveolar walls, and the actual elastic tissue in the bronchial walls that causes a collapse, decreased total surface area, and then also fibrosis. In asthma, there's bronchospasm. In the later stages, the bronchial smooth muscle becomes super hyperresponsive, lots of edema of the walls, and potentially mucus that accumulates there. In bronchiectasis, there is massive amounts of mucus that are accumulating within the airways due to these particular causes, or there's a chronic inflammatory assault to the airway that's causing an increase in amount of mucus to accumulate. Now, what does that increased mucus lead to? What's the problem? Let's talk about that. So here, we have all this mucus that's just accumulating. When mucus accumulates, what do you think it's supposed to kind of like trap in it? Imagine you have a big, thick mucus plug here. Guess what's unfortunately sometimes trapped in this little area here? Lots of microbes. And if these microbes get trapped into this area, not only can they cause infection, but they could potentially cause inflammation as well. And this could cause agitation or inflammation or damage to the actual bronchial epithelium. When that happens, it causes immune system cells to come to the area where this actual destruction or inflammation is occurring. What kind of immune system cells come to the area? One of them is neutrophils. And guess what neutrophils release? They release tons of reactive oxygen species and proteases. That should sound familiar. These T cells come to the area. So different types of lymphocytes come to the area and release lots of cytokines, multiple different types of inflammatory cytokines. And then on top of that, these epithelial cells, whenever they're inflamed, they release something called transforming growth factor beta. We talked about that within COPD. And that tells the fibroblasts to make what's called fibrous tissue. So now all of these things start to occur. Reactive oxygen species and proteases, what do you think they start doing? They start causing destruction of the elastic tissue within the basement membrane. What do you think a lot of these inflammatory cytokines do? They also cause inflammation. Guess what that does? That causes bronchoconstriction. On top of that, these cytokines also stimulate your mucus-producing cells to increase and worsen the already present mucus production. And then on top of that, the fibrous tissue starts laying down fibrous tissue around the actual bronchial walls to again be more of a protective response from that massive inflammation. What does this start to look like? Look at this poor little bronchial. This poor little bronchial has elastic tissue destruction around the walls. What's elastic tissue supposed to do? Well, normally it allows for you to be able to kind of stretch and then also recoil. But if I lose that ability for the actual structure to be able to recoil naturally, it can start to balloon out. And as that starts to balloon out due to the elastic reduction, what happens to the actual airway in this area? You get a localized bronchodilation. But on top of that, here's the problem. Maybe between those areas of the destroyed elastic tissue, guess what? I have a lot of tissue laid down here. Fibrous tissue. And so all this fibrosis may cause narrowing of the airways. So you may have narrowed portions and bronchodilated portions. On top of that, what else did I say was happening? Because of a lot of the cytokines that are being released, what happens to the smooth muscle? It undergoes massive amounts of bronchospasm. And because we already have lots of mucus production, but the inflammation worsens the mucus production, there's going to be so much mucus that it's absolutely insane. So these are the really important pathophysiological features that I want you to understand for bronchiectasis. Now, let's start talking about what do these diseases look like. All right, guys, so now let's talk about the features and complications of these obstructive lung diseases. We're gonna first start with COPD. And one of the important things that you may be asked about on the exam, even though they can coexist, it's important to remember this, they can coexist, and it may be very difficult to delineate them. For your exam, you should be able to understand the difference between chronic bronchitis and emphysema, which is, again, a part of the COPD category. So we know that these patients have some type of tobacco use or excessive exposure to pollutants, or if they have emphysema, with the pan-acinar or pan-lobular emphysema affecting the bases, it could be alpha-1 antitrypsin deficiency. But either way, one of the big things here is how to differentiate these two, especially on the exam. With chronic bronchitis, we call these patients blue bloaters. Let me explain why. In patients who have chronic bronchitis, they may have a bloated type of look. And the reason for this bloated type of look is a couple different reasons. One is, if you think about it, if a patient has COPD, one of the problems is that they have a lot of bronchospasm, they have a lot of mucus in the airways, and that's obstructing air from being able to get out of the lungs. If you obstruct air from getting out of the lungs, what happens to the lungs? They get bigger because you can't exhale out the CO2. So these patients may have what's called hyperinflation of their lungs. If you hyperinflate the lungs, what that may do is push the diaphragm down. Imagine this entire thoracic cavity is just filled with air because the lungs are hyperinflated. It can push the diaphragm down and cause all the abdominal organs to protrude outwards, giving somewhat of this obese type of appearance. If that's not enough to make them look bloated, on top of that, we'll explain this in a second, but patients who have chronic bronchitis, they're at higher risk of what's called hypoxemia and hypercapnia, meaning that they have low oxygen levels in the blood and high CO2 levels in the blood. And I'll explain why later. But because of that, when you have low oxygen levels in the actual blood and high CO2 levels in the actual blood, what happens is that it's usually because of some type of problem in the actual alveoli. They're not getting enough ventilation to particular alveoli, so we don't send blood to that alveoli. And so the way we don't send blood is we constrict the blood flow to the poorly ventilated alveoli. And that puts a lot of stress on the right side of the heart, to the point where the right heart starts to fail. When the right heart fails, what do we know about this from our cardiology section? If the right heart fails, blood backs up via the superior vena cava, causing JVD. So then you get some swelling potentially of the upper neck area. Then on top of that, it also moves inferiorly via the inferior vena cava, causing swelling of the liver, hepatomegaly, causing fluid to accumulate in the abdomen, ascites, and then causing fluid to accumulate in interstitial spaces in the lung, causing pedal edema. This collectively, and we'll talk about this in a little bit, whenever you have JVD, hepatomegaly, and pedal edema, this is collectively due to right heart failure, and this is secondary to what's called cor pulmonale, which is due to some type of chronic bronchitis. So you may see this. So the reason why they have this type of blue bloater, they look bloated, is because the obese factor, because of their abdomen being pushed out, but their abdominal organs being pushed out, because lungs being hyperinflated. And the second reason may be due to right heart failure. The other thing for these patients is that they may have the bluish discoloration because of the point of what's called cyanosis, and I'll talk about that in just a second. But the other key points that you want to remember for patients who have chronic bronchitis is some of the other features. What did I tell you about their airways? They have lots of mucus. Chronic bronchitis, by definition, is a productive cough for greater than 3 months for 2+ consecutive years. So one of the key features in differentiating these is that patients with chronic bronchitis have a very productive cough in comparison to emphysema, where they have more of just like a mild cough. It's not super productive and consistent. That's one of the big differences. The other thing is when you have all of this mucus accumulating within the airway. Imagine that a patient takes a deep breath in. When they take a deep breath in, air has to flow through this airway and through this mucus plugged airway. When that happens, it produces this kind of like snoring sound, and that's called rhonchi. And if you have the patient kind of really cough and cough, it may clear that actual mucus secretions out of the airway, and the rhonchi may potentially disappear. So that's one potential thing that you can see because of the mucus in their airways. The second thing is when they exhale, the air that's actually having to be leaving the lungs and going out into the atmosphere has to move outwards through that tiny little mucus airway. And that air that's having to move through that tiny little airway is going to cause wheezing. So we'll hear wheezing potentially on expiration and maybe rhonchi on inspiration, and they'll have a very, very productive cough in comparison to emphysema. And then the bloated appearance is due to right heart failure and abdominal obesity due to the diaphragm being flattened and pushing the abdominal contents forward. Okay, with emphysema, we call these patients pink puffers. And the reason why they're pink puffers is pink meaning that they don't have a significant degree of cyanosis. And again, I'll explain the cyanosis on the bottom part of this diagram. But again, emphysema patients, they don't have cyanosis, meaning that they're not super hypoxemic and they're not super hypercapnic, okay? Where does the puffer part come into play? The puffer part comes into play because if you imagine if you're trying to breathe out very, very slowly, you're breathing with pursed lips. One of the key features that you may see in the clinical vignette for a patient who has emphysema is that they breathe or they exhale by pursed lip breathing. And the reason why is actually pretty cool. Imagine that you breathe and exhale very slowly. What happens is you allow for the pressure in the lungs to stay high. So what this pursed lip breathing does is it keeps, it increases the airway pressure. And that's a really cool concept. And the reason why is if you think about these patients' bronchioles, think about them. If you think about these patients' bronchioles, and whenever they're trying to exhale out air, whenever they're trying to get air out of their lungs, right? What did I tell you is that tissue that's on the outer part of the bronchioles that helps them to prevent them from collapsing? Elastic tissue. What happens in emphysema? You destroy that elastic tissue. So whenever they exhale, guess what happens to their tiny little bronchioles? They collapse. And when they collapse, it's hard to be able to get air out. So what happens is if they breathe really, really slowly through that pursed lips, it helps to be able to increase the pressure in their airways to keep these bronchioles just a little bit more open to allow for more air to exhale out. That's a really cool thing. So look for pursed lip breathing in patients with emphysema by trying to keep their airway pressure open to keep their bronchioles somewhat open. Okay, the other thing is, again, big differentiating factor, mild cough, productive cough for chronic bronchitis. They'll also have some wheezing because they may also have a little bit of mucus within their airways, which can be, again, reducing the amount of air that's flowing out of the lungs during expiration. Here's the real big thing though. Because they're getting little air out, their alveoli and their lungs get super hyperinflated. They get crazy hyperinflated because, again, we're trying to get the air out, but we can't because the bronchioles are collapsing, and this is just reducing the amount of air that's getting out. So they have massive air trapping. Because of the air trapping, their lungs get huge. And because of that, imagine having all of these large lungs. When you're trying to listen, it's very difficult to be able to hear very good breath sounds because their lungs are so large. They're so large that whenever they actually have to take a breath in, they can't take in very much air because their lungs are already really big. So imagine having big lungs, pretty much almost already filled, and you have to try to bring air into those already filled lungs. It's very difficult. And so oftentimes they'll have decreased breath sounds. So again, big thing, both of them may have wheezing. This one will have rhonchi, chronic bronchitis, and productive cough. This one will have a mild cough and low or decreased breath sounds because of massive hyperinflation of their lungs. The other thing is that these patients are super dyspneic. Imagine how difficult it would be. Imagine your lungs are already filled. They're already filled really, really, pretty good. You have to take a breath in, but the breath that you can take is very small. So you're breathing super quickly over time. You're going to become very short of breath, and that shortness of breath is going to lead to you having to breathe and breathe and breathe at a fast rate for long, long periods of time. And that exerts a lot of energy. And as you use and use tons of energy, guess what starts to happen to these patients? They start to become cachectic and thin. So that's one of the big things. That's why whenever you see a patient who has emphysema, they're more likely to look cachectic and thin appearing, and then their chest is barrel chest. So if you were to look from a side view, their diameter from anterior to posterior is gargantuous. And the reason why is their lungs are super hyperinflated. So it causes their chest to actually barrel outwards, and again, anteriorly and posteriorly. So they have what's called an increased anterior posterior diameter, which we also refer to as a barrel chest. And they're thin because of the amount of work or breathing that they have to do to be able to compensate for a little air that they can bring in. Pretty interesting. All right, so now that we understand this, the basic concepts of how they physically present, what I want to understand is a little bit more about the bluish, so when we say blue bloaters, they're cyanotic. So there's a degree of hypoxemia and hypercapnia. I want to understand the difference here that you can see between chronic bronchitis and emphysema. And then we'll talk really quickly about some of the complications that you can see with these two. All right, so here's the really interesting thing with chronic bronchitis. So still, we're talking about chronic bronchitis over here, emphysema over here. So again, I want to keep having some differentiations, even though they can coexist. It's important to know the difference between these on the exam. So we have the basic kind of like physical exam and symptomatology types of presentation here. To go a little bit more into the concept of the bluish or pinkish type of like situation for pink puffers and blue bloaters, we got to kind of zoom in into the alveoli bronchial area. What we know about chronic bronchitis is that there's a lot of mucus, right? Lots of mucus within the airway, some bronchospasm, so we know these concepts here. So there should be a degree of mucus accumulation and bronchospasm. The problem with that is what? Well, one of the problems here is that if I want to bring oxygen into this airway, I have to try to push it through this like mucus plug. It's going to be really difficult to push oxygen to this alveoli. In comparison, look how easy it would be to push oxygen into this alveoli. So if I were to compare which one is going to have more oxygen in this alveoli, the one with the mucus plug leading to less oxygen or the one that's just wide open? Pretty obvious, right? This one will get well ventilated and this one will get poorly ventilated because of that mucus, okay? The other concept here is CO2. So CO2 has to be exhaled. So it has to cross the actual capillary blood and then move out here and then again move out of the lungs. And then over here, same thing, has to move across the pulmonary capillaries and then out of the lungs. Which one would it be able to move easily out from? This alveoli area or this alveolar area? In this situation, there's going to be less CO2 that's leaving through this area. And so CO2 will build up in the blood in this particular scenario, and then you'll have less CO2 in this area of the blood because it's going to easily clear the CO2 from this particular area. Okay? Pretty straightforward concept. So, in this alveoli that has a big mucus plug or bronchospasm, less oxygen getting in, less CO2 getting out. Now, here's the cool thing. Our lungs are really smart in a way that it likes to make sure that when we send blood to an alveoli, I send blood to the alveoli that's well ventilated. I don't want to send oxygen, or blood particularly, to an alveoli that's poorly ventilated. Out of these, which one is poorly ventilated? This is the poorly ventilated one. So because this is poorly ventilated and this one is well ventilated, I'd want to increase the blood flow through this one and then decrease the blood flow through this pulmonary vessel. How do I do that? I have to intensely vasoconstrict this vessel and divert the blood away to this vessel. That's one of the things that happens in this situation. And the reason why is you're going to get less movement of oxygen. So if there's less oxygen coming into this alveoli, that means that there's less oxygen that's going to move into the blood here. That means that the oxygen inside of the blood in this particular situation will be low. What is that called whenever you have low oxygen in the blood? It's called hypoxemia. What is it called whenever you have high CO2 levels within the blood? That's called hypercapnia. So these are the potential situations that I could see. I could see a patient developing hypoxemia, and I could see them developing hypercapnia. Now, the way that I can try to be able to protect this from happening is I can vasoconstrict the pulmonary vessel to this poorly ventilated alveoli because of the mucus or the bronchoconstriction, and then send the blood to this good alveoli because it's going to get lots of oxygen moving into the blood here and not have any hypoxemia, and I'm going to clear the CO2 out of the blood here so I'm not going to have hypercapnia. This is a very interesting type of concept. So I want to undergo what's called pulmonary vasoconstriction to this particular area. I want to pulmonary vasoconstrict the poorly ventilated area and then increase the blood flow to the well-ventilated area. Now, in patients who have chronic bronchitis, this hypoxemia is very severe and their hypercapnia is very severe. Because of that, when you're hypoxemic and you're hypercapnic, that leads to that cyanotic appearance, that bluish discoloration, if you want to think about it. Because if you have hypoxemia, you're not giving enough oxygen to the tissues, and so the oxygen content of the hemoglobin within the blood is decreased. There's lots of deoxyhemoglobin, and therefore more of a cyanotic type of appearance. In patients who have emphysema, there's not as much of that type of problem, and I'll explain why in a little bit. But because a patient becomes hypoxemic, what happens? There are less ventilated alveoli is what the brain starts to think. It says, oh, there's less oxygen in the blood. You know what I should probably do? I should have the patient breathe faster and breathe deeper. And so they develop dyspnea and they develop tachypnea in a way to be able to increase their oxygen and decrease their CO2. That's their compensatory mechanism that they're thinking is going to happen. But instead, it just makes the patient have to work harder to breathe. That's one of the clinical features here to think about. And then they may have cyanosis because of, again, that decreased oxygen and that increased CO2, but more particularly is the decrease in oxygen, okay? Now, that's a really interesting type of concept. Now, the other thing that you want to think about here is that what can this do to the heart? Because remember I told you they can develop right heart failure. This is why. The reason why is if let's say that here, this alveoli has a big mucus plug, right? So here's a big mucus plug in this alveoli. And then here, there's a big mucus plug in this alveoli in a patient who has chronic bronchitis. If I have little oxygen getting into this alveoli and little oxygen getting into this alveoli, do I want to send blood flow to these alveoli? No. And so what will I do? Pulmonary vasoconstrict. So I'm going to clamp down on these vessels. I'm going to squeeze these vessels to make sure that blood is not going to these poorly ventilated alveoli. When I do that, I increase the pressure inside of the pulmonary circulation. What does that do to the right side of the heart? It makes it have to work harder. If the right heart starts having to work harder, it'll originally start to hypertrophy. But that hypertrophy will eventually lead to right heart failure because it won't be able to maintain that contractility over time. And that'll cause blood to backflow into the superior vena cava, causing JVD, backflow into the inferior vena cava, causing hepatomegaly, ascites, and pedal edema. And this is what we call cor pulmonale, right heart failure due to underlying pulmonary vasoconstriction due to an underlying lung disease such as chronic bronchitis. One more concept that we also have to understand. If I have a lot of mucus that are plugging up this airway, what does that do? Can I clear bacteria? Can I clear bacteria if there's a bunch of mucus that's just clogging up the airway? That's actually, let's say there's bacteria in this area of the alveoli and I want to be able to clear that bacteria. I can't because the mucus is blocking me from clearing it. And so that can increase the risk of bacteria accumulating just distal to where the mucus plug is, leading to bacteria increasing, colonizing, thriving, and infecting the actual respiratory tissue, increasing the risk of pneumonia. So in patients who have chronic bronchitis, they're at high risk for pneumonia. They're at very high risk for cor pulmonale and right heart failure. And there's one more thing they're at high risk for. Whenever a patient is persistently hypoxemic, so they have low oxygen levels within the blood, what it does is it tells our kidneys and says, hey, there's very low oxygen levels in the blood. Maybe another problem is not only the patient is not breathing fast enough, so that's why they get dyspneic and tachypnic, but maybe they need more red blood cells. So why don't you make more erythropoietin? And erythropoietin will tell the red bone marrow to increase the production of red blood cells. And if I have more red blood cells, I have more things to carry oxygen. And maybe that'll improve it, but it doesn't. Instead, it causes these patients to develop something called polycythemia. So they increase the number of red blood cells. So in patients with chronic bronchitis, look for some of the big differences between that and emphysema: cor pulmonale, which is right heart failure, increased risk of pneumonia, and again, secondary polycythemia, as well as a productive cough is a very characteristic feature, and a bloated type of appearance. And what that means is JVD, hepatomegaly, ascites, pedal edema, and abdominal obesity due to the diaphragm pushing down and pushing the abdomen forward. okay? And on top of that, they have the bluish discoloration due to hypoxemia, the cyanosis, due to very little oxygen getting into poorly ventilated alveoli. Okay, when we compare that in a patient who has emphysema, in early emphysema, they don't have that degree of hypoxemia and hypercapnia. They have very mild hypoxemia and very mild hypercapnia. The reason why is their problem is not as much mucus. So remember that you will have a little bit of mucus production in emphysema, so there will still be a little bit, but it's going to be nowhere near the amount that you would have in a patient who has chronic bronchitis. So that's one of the big differentiating features. But there still will be some mucus. The problem here is that this actual bronchiole will be open during inhalation. During inhalation, it'll be open, right? So you'll be able to bring what into the alveoli? Easily, you'll be able to bring oxygen to this alveoli and oxygen into this alveoli, okay? And because of that, oxygen will be well ventilated in this one and properly ventilated decently in this one. So oxygen will be able to move into the blood relatively easy, and you'll get increased oxygen in the blood, increased oxygen in the blood. That's not the problem. The problem is when the patient exhales. When they exhale, the elastic tissue that's supposed to prevent the bronchioles from collapsing no longer prevents them from collapsing. So when they exhale, what happens, my friends? What happens here is the bronchioles collapse really powerfully during exhalation. So oxygen got in pretty well into the alveoli during inhalation, but now CO2, which is supposed to be cleared, is not going to be exhaled as easily. And so what happens to the CO2 within their bloodstream? That does rise. So the CO2 will rise within their bloodstream. So these patients will have a degree of hypercapnia. They won't have a very significant hypoxemia. One of the reasons why they may have a very mild hypoxemia is not due to the amount of oxygen getting into the alveoli. What's the problem with emphysema? What happens to their total surface area? Their total surface area decreases. And if your total surface area decreases, that means that less gases are potentially exchanged across the alveoli. So the amount of oxygen getting into the alveoli is normal, but maybe the amount of oxygen that's moving across the actual respiratory membrane into the blood is a little less. And that's where you get a little bit less oxygen. So they have a very mild hypoxemia, not because they have difficulty getting oxygen into the actual alveoli, because they have a problem being able to diffuse it across the alveoli into the blood. So this is due to a decreased total surface area. And they have increased CO2. Why? Because the bronchioles collapse during exhalation, which traps the CO2 in the alveoli. I hope that makes sense. Because they have so much air trapping in their lungs, imagine their lungs are filled with air. Every breath that they have to take, they have to add more air into their already filled lungs. So imagine you're already filled up. You're having to take these little breaths of air, and so it causes this degree of dyspnea and tachypnea to try to be able to properly ventilate, but again, your lungs are already hyperinflated. So that's why these patients will have dyspnea and tachypnea. It won't be due to their hypoxemia, because it's very, very mild. It'll be due to their air trapping, and they're having to work very hard to breathe in small volumes, still ventilate, but again, it's a problematic issue for them. One of the big problems for these patients, because their airways are so hyperinflated, is they have a significant degree of air trapping. And when they air trap, imagine all this air starts kind of ballooning up and causing these things called bullae or blebs. They're like these little kind of like pimples popping off of the lung. These things are very high risk. So now, for whatever reason, a patient's under positive, they're being mechanically ventilated, they take some type of deep breath, whatever may happen. Sometimes it can be completely spontaneous, no trigger whatsoever. This thing can pop. And if it pops, it'll push air directly from the lung into the pleural space. And all that air will start to accumulate into the actual pleural space and start pushing on the lungs. What is this called? A pneumothorax. So patients with emphysema, due to their air trapping effect, are at very high risk for pneumothorax. Not so much hypoxemia leading to right heart failure, cor pulmonale, and secondary polycythemia. In the later stages of emphysema, really late stages, they may have hypoxemia and they may have worsening hypercapnia, which could lead to right heart failure. but not commonly in the early to mid stages. Their primary complication is pneumothorax. So please understand the differences between these two, because now let's talk about asthma. All right, so now let's talk about the features and complications of asthma. So in a patient who has asthma, what's the basic kind of trigger? There's either allergic or non-allergic causes. We went over viral upper respiratory tract infection, cold, air, exercise, beta blockers, GERD. We went over the Samter's triad, which remember aspirin use. And then we talked about all the allergens, right, and the atopic triad. So either way, we know that those are the triggers. Patient develops an intense bronchospasm, so they have bronchial smooth muscle constriction. On top of that, they have bronchial edema, which also narrows their airway. When you have that intense bronchoconstriction, bronchial edema, and in the later stages, even some mucus secretion, this is really going to narrow the actual lumen of the bronchioles. What happens with that is that whenever these patients are trying to exhale, they have a severe wheezing. So they have a significant expiratory wheezing where it's even worse and louder at the end of expiration. So end expiratory wheezing is a very common feature for these patients. Also, they will have a cough. Their cough, though, because theirs isn't an intense amount of mucus in comparison to COPD, shouldn't be a very intense, productive cough. It should be more of a dry cough because it's a lot of bronchial edema and an intense bronchial smooth muscle constriction. In the late stages, they may have a little bit of mucus production as a protective response, but primarily bronchial edema and bronchoconstriction, which will produce an intense expiratory wheezing. Now, what is a very ominous sign is a silent chest. When you go to listen to the patient and you hear almost no airflow moving in or out, that means that they have a severe obstructed airway. That means it is so obstructed that literally no air is getting into the chest, or they're so hyperinflated because they're trapping so much air. So imagine this. Imagine like I have here, here's my bronchial, and imagine all of this is all the air in the alveoli here. I am trying to get CO2 out, but I cannot because it is so bronchoconstricted and so edematous. It is literally impossible to get CO2 out. So no CO2 is moving out of the airway. Because of that, these lungs are already hyperinflated. They try to take a breath in, they can barely take any air in because their lungs are already super inflated. And on top of that, their airways are so obstructed that it's very, very difficult to be able to get O2 into the actual lungs. So this is a very scary finding when you have a patient who has a silent chest. This is a very severe bronchoconstriction, very severe bronchial edema, and a very severe asthma exacerbation. So again, think about these as the particular findings of a patient with asthma. Now, what are some other things that I want you guys to understand? Let's come down and talk about that. Now, when a patient has very severe asthma, we know that there is going to be an intense degree of bronchospasm. This intense degree of bronchospasm prevents CO2 from being able to be exhaled, right? So CO2 wants to be able to move from the blood into the alveoli and then be exhaled out. That's the normal pathway for CO2. But in this situation, it's being prevented because these bronchioles are so constricted that it's going to reduce CO2 outflow. And that's going to cause hyperinflation. That hyperinflation is a problematic issue because the reason why is when your lungs are already hyperinflated, it's very difficult to be able to bring air in on top of those already filled lungs. And so because of that, they take in smaller amounts of air in. And on top of that, if you have an intense bronchoconstriction, it's also going to reduce the oxygen coming into the alveoli. So they may have a reduction of air coming into the alveoli. And if there's a reduction of O2 coming into the actual alveoli and a reduction of oxygen moving into the blood, this may cause particularly what's called hypoxemia. So these patients may have a degree of hypoxemia. Plus, we want CO2 to get out. If it's being trapped, the CO2 will build up in the bloodstream, and that is called hypercapnia. So these are some of the potential features that you can see in a patient who has a very severe asthma exacerbation. And what we know is that hypoxemia will activate our sympathetic nervous system. And our sympathetic nervous system will say, oh, we're hypoxemic and we're hypercapnic. We must not be breathing good enough. We must not be taking in deep breaths and breathing fast enough. I'm going to have them breathe deeper and breathe faster. Work harder to breathe. And so what that does is that causes dyspnea and tachypnea and increases their work of breathing. It says, okay, you won't have to work hard, boy. And so it causes the patient to have to use all accessory muscles. Like what way? It might cause them to flare their actual nares to open up the airway there. It may cause them to use some of the accessory muscles like their scalenes and sternocleidomastoid to help with their inspiratory and expiratory response. It may cause them to use some of their actual abdominal muscles to help with their expiration. And so you start to see a lot of work of breathing. And one of the biggest things is looking for them to have tachypnea, dyspnea, and an increased work of breathing. These are scary signs because this could be indicative of a very severe exacerbation. So look for these particular things such as nasal flaring, tripoding, accessory muscle use, abdominal muscle use. These are all concerning signs. So these could be things that you could see as a patient has hypoxemia and hypercapnia due to a massive amount of air trapping for hypercapnia. And because of the air trapping, little air can be brought into the lungs, so less ventilation to the alveoli. And on top of that, the intense edema and bronchoconstriction reduces the amount of airflow into the lungs. And again, this can lead to reduced ventilation and therefore reduced oxygen accumulation within the blood, leading to hypoxemia, less CO2 being able to escape, hypercapnia. The other thing that these things can do, particularly hypoxemia, is it can also increase our heart rate. And so you may have a patient who develops something called tachycardia. So look for that as well as a very concerning sign of an exacerbation. So these are big things to think about. But you know what else is really important for these patients? And patients who have asthma, they also can have, when we think about this concept of here's a normal lung. So here's a normal lung. And a patient who has asthma, they have intense bronchoconstriction, bronchial edema that leads to less CO2 being exhaled. So less CO2 is going to be exhaled out of the lungs. Because of that, this is going to cause air to be trapped in the lungs. So there's going to be lots of air trapping. Whenever there's lots of air trapping, what's really interesting here is whenever you have less CO2 being exhaled, you're going to cause this air trapping effect. This air trapping, it causes the pulmonary vessels, which are supposed to take blood back to the left side of the heart, to be pinched. So imagine these lungs are actually being super inflated and air trapped. What it does is it pinches on the pulmonary veins. So the blood, the actual vessels that are supposed to take blood back to the left side of the heart. So it pinches on the pulmonary veins. If you pinch on the pulmonary veins, you're going to reduce the venous return to the left side of the heart. So the venous return to the left side of the heart is going to be reduced. So you have a reduced left ventricular filling. If you don't fill the ventricles very well, right? So you have a patient who their lungs are super air trapped. Whenever they are super air trapped, especially during inspiration, they're so filled, they compress and squeeze on the pulmonary veins. And again, in these patients, their lungs are filled all the time during expiration and inspiration because they're hyperinflated. Because they're so hyperinflated, especially during inspiration, they squeeze on the pulmonary veins. When they squeeze on the pulmonary veins, less blood flow comes into their left ventricle. And again, this is all during inspiration. So during inspiration, there is a massive pinching of the pulmonary veins because we're going to expand them even more, compress on the pulmonary veins, reduce the left side of the venous flow. If we reduce the left ventricular filling, what is going to happen then to the left ventricular cardiac output? If you have a reduced left ventricular filling, meaning that you have a reduced preload, that's going to lead to a subsequent reduction in cardiac output. If you reduce the cardiac output, you could potentially reduce the patient's systolic blood pressure. If I reduce the patient's systolic blood pressure during inspiration greater than 10 millimeters of mercury, this is called pulsus paradoxus. This is a very important thing that you can see in asthma and not really in any of these other obstructive lung diseases. So think about this. And what this would look like is if I had an arterial line, on the bottom part here is the diastolic pressure. On the top part here is the systolic blood pressure. Here's what their actual arterial pressure waveform would look like during expiration. And during inspiration, you would see that their systolic blood pressure would drop 10 millimeters of mercury or more during inspiration. And what's the reason why that it would do that? Because the patient's lungs are already hyperinflated at the end of expiration. You try to take air in, take more air in on top of those already inflated lungs, they're going to expand and squeeze on the pulmonary venous vasculature, reducing the actual amount of blood coming back to the left heart. If I don't get blood coming back to the left heart, we get a reduction in left ventricular preload during inspiration, a reduction in left ventricular cardiac output during inspiration, and a reduction in their left ventricular systolic blood pressure during inspiration. And if it's more than 10 millimeters of mercury, that's called pulsus paradoxus. So don't forget that as a potential complication of a patient who has asthma. All right, so we know with asthma, they have dry cough, inexpiratory wheezing, a silent chest is an ominous signing of a very severe bronchospasm. They also have dyspnea, tachypnea, and increased work of breathing, especially during exacerbations because they're super bronchoconstricted, less CO2 getting out, causing air trapping, making it difficult because their lungs are hyperinflated. It's hard to bring more air into a hyperinflated lung. Plus, if the bronchioles are super constricted, it's hard for airflow coming in, less ventilation to the alveoli, less oxygen moving into the blood, hypoxemia. The hypoxemia creates a compensatory response where the patient has to breathe harder and faster to try to bring more air into the lungs. That leads to dyspnea, tachypnea, and increased work of breathing. And hypoxemia will also try to make their heart beat faster, leading to tachycardia. All right, my friends, now let's move on to bronchiectasis. All right, guys, so now let's talk about bronchiectasis. So now this one may sound similar to chronic bronchitis, but there is some couple different features that help us to really delineate and differentiate between those two. With bronchiectasis, what I tell you was the big thing. Obviously, they have bronchodilation due to the elastic tissue destruction. They also have fibrosis due to a lot of fibroblast activity. They have lots and lots of mucus production. That's one of the big things. And they also have bronchospasm. So because of that, we can see a lot of the similar features between that and chronic bronchitis, except their cough is going to be very productive and very foul smelling. Okay, so a very productive and foul smelling cough due to an excessive mucus production. I think it's one of the big key things to remember about bronchiectasis is that there is a massive amount of mucus that is accumulating, and that's one of the kind of driving factors behind the disease. So productive foul smelling cough. They'll also have wheezing because you're going to have mucus that is obstructing the actual airway as air is supposed to be leaving the actual lung. So during expiration, we'll hear a wheezing. During inspiration, you may hear a lot of kind of a snoring sound because there's a narrowing of the airway. And when air is trying to move past the actual mucus-filled airway, it may cause this snoring sound, which may disappear. If you have the patient kind of really cough and expectorate some of that mucus up, it may clear the airway and you might not hear the wrong guy anymore. The other thing, it's not pathognomonic. It's important to remember that. But in patients who have bronchiectasis, they also have a degree of hypoxemia. And that chronic hypoxemia may cause a change in the configuration of the nail bed to where it kind of really bulges out and causes clubbing of the digits. It is not pathognomonic, but it's something to think about that you may see more commonly in a clinical vignette for bronchiectasis than all of the other obstructive lung diseases. Another really big feature here that differentiates is hemoptysis. Now remember I told you that there's lots and lots of mucus within this patient's airway. Because of that, it causes lots of inflammation. Lots of inflammation of the bronchial walls, and then bronchodilation really thins out the bronchial walls. Well, you have these blood vessels here. These are called your bronchial blood vessels. Because there's a dual blood supply to the actual lungs. There's the pulmonary vessel supply, and then there's the bronchial supply, which are these. As you have lots of inflammation of the bronchial walls, it can get very close to the little bronchial vessels that are feeding the actual bronchial tissue. And if it just is enough to erode its way into the actual bronchial wall and cause these bronchial blood vessels to get eroded and eaten at, it can cause blood to enter into the lumen of the actual bronchus. And this can lead to hemoptysis, which is coughing up of blood. So you may see this in patients with bronchiectasis. The other thing here is because they have all of these mucus that is actually accumulating in their airways, again, what are they going to have a hard time being able to eliminate from the actual bloodstream? CO2. CO2 will not be exhaled as well, so CO2 will build up in the bloodstream. What is that called? This is called hypercapnia, so they may have some degree of hypercapnia. On top of that, it's also going to cause less oxygen to be able to come into the alveoli because of these bronchioles being obstructed and occluded with all this mucus and also having a degree of bronchospasm. So less oxygen will be able to get into the alveoli and less will pass into the blood. And if there's less oxygen in the blood, what is this called, my friends? This is called hypoxemia. And so in these patients, you may see a degree of hypercapnia and hypoxemia. And let's see if you guys can remember, what does the compensatory response to hypoxemia? To increase your respiratory rate. So it has them breathe harder, tachypnea, breathe faster and breathe harder, and cause some shortness of breath, dyspnea, And it may also cause a compensatory increase in the heart rate. So these are potential things that you can see in these patients, okay? Now the other really big thing here, just like in chronic bronchitis, is because you have this mucus that is just plugging up the airways, one of the big functions here is that we don't want bacteria to kind of really colonize, right? But if all this mucus is plugging up, so let's imagine here that the mucus is getting plugged up all right here. These bacteria that are supposed to be moved upwards and cleared stay in this area. And because of that, they can colonize, they can multiply, and then they can start leading to an infection. And if they lead to an infection, this will lead to pneumonia. So patients with bronchiectasis are at very high risk for pneumonia. And you know there's a very special bug, especially in patients who have cystic fibrosis. Because cystic fibrosis is a very high risk cause for patients with bronchiectasis, what is the very specific bug that they can actually accumulate and can cause a lot of problems? Do you guys know what it's called? It's called Pseudomonas aeruginosa. So patients who have bronchiectasis are at very high risk for pneumonia infections due to a nasty pathogen called Pseudomonas aeruginosa. So this is a big thing to think about for these patients. So again, with bronchiectasis, very productive foul-smelling cough, wheezing, rhonchi, hemoptysis, increased risk of pneumonia. They may have a degree of hypoxemia and hypercapnia that causes them to have some degree of dyspnea, tachypnea, maybe even a little bit of tachycardia. Here's the one big thing that I want you guys to remember though. In a patient who has bronchiectasis, one of the classic things that they're going to present on the exam is due to cystic fibrosis. That's going to be the common cause, okay? If a patient has cystic fibrosis, think about some of the other features that they may present in the clinical vignette, that they're trying to point you towards bronchiectasis. In this situation, if a patient has cystic fibrosis, we already know that this is due to a defect in the transmembrane protein that's supposed to pump chloride out into the secretions and yank water into it. But because they're not doing that, they're not pushing chloride and pushing water into the secretions get thick. And that can happen not just in the lungs. You know, when a baby is very young, sometimes the secretions that actually are supposed to help with the actual bowels, eliminating something called the meconium, which is the first stool of the baby, can get really, really stuck inside of the actual bowels. And because that can cause a bowel obstruction, this is called a meconium ileus. So if a baby had a previous history of what's called a bowel obstruction due to meconium ileus, that's something to think about. And really, really young, right? Whenever they're actually just born. On top of that, because the pancreatic ducts also make lots of pancreatic secretions. If the pancreatic ducts actually are trying to make these secretions and they can't actually push chloride and water into it, and the secretions get too thick that they get stuck in the pancreatic ducts, can you secrete pancreatic enzymes into the actual intestines? No. So that builds up, causes autodigestion and inflammation of the pancreas. And eventually that can lead to the pancreas starting to fail, causing pancreatic insufficiency. Look for them to have malabsorption syndromes, lots of kind of nasty diarrhea as well. The other thing is it can cause mucus to accumulate within the airways, causing those bronchioles to get obstructed, causing mucus to accumulate and bacteria to colonize, and leading to bronchiectasis and leading to the dilation of the bronchioles, fibrosis, bronchospasm, and all that mucus production. Last but not least, it's also important, particularly within the development of the vas deferens. And in patients who have cystic fibrosis, they don't form their vas deferens. Are you going to be able to pass sperm on to the other actual sex? No. And because of that, that leads to the actual increased incidence of male infertility. So with cystic fibrosis, not only is it important to be able to remember that it is one of the causes of bronchiectasis. In the clinical vignette, they may ask you, a patient has bronchiectasis, okay, due to cystic fibrosis, what may be some of the other features and complications that you would expect besides productive foul-smelling sputum, wheezing, rhonchi, hemoptysis, increased risk of pneumonia, mild degree of hypoxemia and hypercapnia. What? Look for increased incidence of meconium ileus, pancreatic insufficiency, we already know bronchiectasis, and male infertility. All right, now that we've talked about all the features and complications, we move to the next big part, which is understanding how to differentiate an obstructive lung disease versus something we haven't talked about yet called a restrictive lung disease and other diagnostic tools. All right, guys, so don't poop yourself. I know that this is a lot of stuff. It looks pretty scary, but I promise it's actually not too bad. It's going to make pretty good sense. Now, one of the important things I think that is really, really essential for your step 2 exam is being able to not only differentiate some of the obstructive lung diseases from one another, but it's also really important to be able to differentiate obstructive lung diseases from restrictive lung diseases. And we'll have a separate lecture on that. But for right now, I want to just quickly take the time that while I'm talking about some of these different things called pulmonary function tests, we should not only discuss obstructive lung disease, but throw in a little bit about restrictive, because it's going to help you in the overall end game when it comes to talking about these on your exam. All right, so first thing when we talk about pulmonary function tests, we're going to do some things called spirometry. And what we're going to try to determine is we're going to look at a couple different parameters. When we take a patient who has normal lungs in comparison to obstructed lungs versus restricted lungs, we're going to look at 3 particular things with the pulmonary function test. What I want you to understand is when a patient is breathing, okay, they have normal, healthy lungs. When they're breathing normally, normal, quiet breathing, taking a breath in, taking a breath out, that normal, quiet breathing is this purple kind of line that's oscillating here. That's called your tidal volume. Now, whenever a patient decides to take a deep breath in beyond their normal tidal volume inhalation, so that's called their inspiratory reserve volume. So it's the amount of air that they can forcefully inspire beyond their tidal volume inhalation. That's the IRV. The next one is the amount of air that you can forcefully exhale beyond your tidal volume exhalation. That would be your ERV. So I'm gonna look a little dumb here, but go. That amount of air that I blew out beyond my tidal volume exhalation is called my expiratory reserve volume. The amount of air that remains in my lungs at the end of that forced exhalation is called the residual volume. That's the amount of air that kind of keeps the alveoli open and prevents them from collapsing. And that's an important concept. And what I'm going to do is we're going to take and look at this graph and compare it. What happens to the IRV, the TV, the ERV, and the residual volume in obstructed and restricted lungs? But before we do that, we have to talk about one more thing. There's another terminology which you guys see here called forced vital capacity and total lung capacity. What I want you to remember is that forced vital capacity, FVC, is the combination of your inspiratory reserve volume plus your tidal volume plus your expiratory reserve volume. This is called your forced vital capacity. Your total lung capacity is your forced vital capacity plus your residual volume. So if I go all the way from here down to my residual volume, this is called my total lung capacity. What I want us to now understand is what happens to all of these volumes in a patient who has obstructed lungs versus restricted lungs. Let's take a look here. So in a patient who has an obstructed lung disorder, what is the classical feature, whether it's asthma, whether it's COPD, whether it's bronchiectasis? There's a problem being able to get air out. So because of that, air stays trapped in the lungs. They hyperinflate. They're big old chunky lungs. Because they're big, compliant, very large lungs, what would we expect? We would expect that they're going to have really big, chunky lungs. Now here's what I want you to think about. If a patient has really, really big lungs, imagine how hard it would be to take in. So imagine my lungs are already filled here, right? And I'm going to try to take a deep breath in beyond my normal tidal volume. How hard is that going to be to take in a large volume of air when my lungs are already hyperinflated? Imagine the lungs being already filled almost, and you got to try to take in a lot of air. It's not going to happen. So in these patients, their inspiratory reserve volume, the amount of air that they can forcefully inhale beyond their tidal volume inhalation, is very low. So that is reduced in patients who have obstructive lung diseases because you can't take in a large volume of air because they're already super puffy and inflated. Their tidal volume actually doesn't become affected though, thankfully, right? So that's relatively normal. The amount of air that they can breathe in during normal inhalation and exhalation is the same. Their expiratory reserve volume, the amount of air that they have available that they could forcefully exhale after the tidal volume exhalation, is insane. Because look how puffy these dang's lungs are. They're huge. And so because of that, their expiratory reserve volume is increased, and their residual volume, the amount of air that they have remaining in the lungs after exhalation, is also increased. They're air trapping. So they have a very high residual volume. We sometimes use a very special term here, which I want to write down here for a second. It's called functional residual capacity. So the functional residual capacity, FRC, is elevated in patients who have obstructive lung diseases. Okay, now, let's use this concept of what forced vital capacity is and what total lung capacity is then, right? In patients of obstructive lungs, their lungs are hyperinflated. So the amount of air that they have available to be able to exhale is large. The amount of air that they have sitting in their lungs after they exhale, forcefully exhale, is large. So their functional residual capacity is large. The amount of air that they can try to bring in forcefully is very little because their lungs are already hyperinflated. Think about how much air their lungs can occupy at an entire time. So total lung capacity is the IRV plus the TV plus the ERV plus the RV. In this situation, my RV is massively increased, my ERV is increased, my tidal volume stays the same, my inspiratory reserve volume will reduce a little bit. If that's the case, this is actually going to cause the lungs to have a very, very large total lung capacity. The total lung capacity for obstructive lungs is increased significantly, okay? And that is in part due to these two factors. The ERV and the RV significantly increase. Just to put it in perspective, let's give it a double arrow. Let's give this a double arrow here, and let's give this a double arrow here, okay? And therefore, the functional residual capacity is going to increase. Okay, the forced vital capacity is the IRV plus the TV plus the ERV. Well, the ERV is increased, the IRV decreases. So the FVC may decrease, but it almost may be normal. So sometimes in these patients, it can vary from where it can actually be relatively normal to mildly decreased. It can be normal to mildly decreased. Usually in the early stages of obstructive lung disease, it's relatively normal. As they get later and later and later into the disease, their FVC starts to decrease. So that's what I want you guys to remember. Their FVC may be relatively normal in the early stages and decrease as we get to the later stages, okay? That's this component here for obstructive lungs. Now let's go to the restrictive lungs. For the restrictive lungs, look at the size. Oh my gosh. Big old suckers, baby suckers, right? In restrictive lung disease, we haven't talked about this yet, but in their situation, they're very, very fibrotic. They're super, super kind of like elastic, and they just don't want to be able to expand, and they just want to collapse naturally. They just don't want to be able to bring air in, and they collapse really easily. So it's really hard to fill these lungs. And they don't have a lot of air in them. They're very, very tiny. So because of that, imagine this. How hard is it going to be able to bring air into these stiff, non-compliant lungs? Very difficult. So being able to forcefully inhale a ton of air, do you think I'll be doing a good job at that? No. So these patients' IRV is reduced. Tidal volume doesn't really change, thank goodness. That's relatively straightforward. The amount of air that they can bring in normally during quiet breathing and out during quiet breathing is the same. Their ERV, look how little their lungs are. They don't have a lot of air that are available for them to exhale. So because of that, their ERV is reduced. And then the residual volume, the amount of air that they'll have remaining in their lungs at the end of a forced exhalation, is also really little. So there's a residual volume will be reduced. And the combination of these two, which is called our functional residual capacity, will be reduced. If we take all of this into consideration and look now at the total lung capacity, which is all of these things added up, there's a lot of down arrows, my friends. So what do I expect to happen to the total lung capacity if I added all of these up? I expect it to be low. So I'm going to have a very low total lung capacity. Forced vital capacity is the IRV plus the TV plus the ERV. Two down arrows and one's kind of normal. I expect the actual FVC to be low. And so in this situation, I want you to remember that the FVC is really, this is why I want you to stress this. FVC is really low in patients with restrictive lung diseases. In obstructive lung disease, it can be normal to slightly decreased. Okay, that's one of the big features to understand here. Now, we've had a basic concept of these numbers whenever we're having a patient breathe into what's called a spirometer. So basically, all of these things, we're taking a patient who has normal lungs, obstructive lungs, restrictive lungs, having them breathe into this spirometer apparatus and then give us all of these particular things and help us to be able to kind of determine, based upon these volumes, where they kind of fall within the obstructive versus restrictive versus normal lungs. We can further extrapolate this. And really what happens when we do these spirometer devices, we actually get these things called flow volume loops. So what this is going to show us here is on the x-axis here, we're going to have volume. On the y-axis, we're going to look at the flow of air. On the top part, it's going to be expiration. On the bottom part, it's going to be inspiration. Okay? And then here's 0 liters, 2 liters, 4 liters, 6 liters, 8 liters. So when a patient takes a breath in, normal lungs, they're going to inhale. When they inhale, they're going to potentially inhale beyond what they already have in their lungs. So here, this patient's going to start taking in air, and it's going to go from 2 liters during their inspiratory process to about 7 liters during their inspiratory process. Then during expiration, they're going to have a normal flow outwards, and then again, that'll start to decrease and take them back to their original volume. Okay? Now, what this gives us is kind of a couple different things. From this point here, from the moment of inspiration all the way here, expiration all the way here. This is going to continue. Think about this. I take a deep breath in beyond my tidal volume inhalation. This would be my IRV. And then I take and I breathe out as much air as I forcefully can during exhalation. This would be my ERV. And then the volumes that are actually just going to be during the normal quiet breathing process, my tidal volume. So my tidal volume plus my IRV plus my ERV is my forced vital capacity, right? IRV plus TV plus ERV is forced vital capacity. So from this point here to this point here is what's called my forced vital capacity. The amount of air that remains in the lungs after I've exhaled all the air that I possibly can is what? My residual volume. And then if I were to take the residual volume plus the forced vital capacity, what would this be? This would be my total lung capacity, this entire thing here. This is for normal lungs. So what I want us to do now is imagine, this is what the normal flow volume loop will look like in normal healthy lungs. If I have a patient who has obstructive lungs, what do I know? What do I know about these particular parameters in a patient who has obstructed lungs? Well, they're hyperinflated. If they're hyperinflated, they're going to have a high residual volume. We know that if they have a high residual volume, what's that going to do? What we know is an increase in residual volume plus an increase in their expiratory reserve volume plus a normal tidal volume and a mild decrease in their IRV causes their total lung capacity to increase. And we said that their forced vital capacity, which is their IRV plus their TRV plus their ERV, can do what? It can be somewhat normal to slightly decreased. So if I were to kind of do this, it would be here to here. Okay? So somewhere between normal to slightly decreased. What would that look like in comparison to the normal graph, which is here in black? Well, now, I would expect my forced vital capacity to be what? Potentially the same, but I would expect my residual volume to be increased. So what I'm going to do is, look where my graph starts here now. I'm going to take a deep breath in beyond my normal tidal volume inhalation, and then I'm going to exhale as much as I possibly can during exhalation beyond the tidal volume exhalation. So this is going to be my entire forced vital capacity. So from here to here is my forced vital capacity. If I think about that one in comparison to that one, it might be normal to almost slightly decreased in comparison to normal. But here's the big thing. The amount of air that remains in the lungs after that forced exhalation is called what? My residual volume. So my residual volume is what in this diagram? It's super increased. Because my residual volume increases, it shifts the actual curve of this graph to the left. That's an important thing to be able to remember. So when you're given a graph on your exam and comparing to say, which one of these do you think this lung disease is, based upon the flow volume loop? Is it obstructive or restrictive? If the graph is shifted to the left in comparison to the normal lungs, it's an obstructive lung disease. And in these situations, due to a massive increase in their residual volume, and what will happen to their total lung capacity? Look at this. Look at this son of a gun. It's gargantuous. They have a massive total lung capacity that's increased. And on top of that, you know what else is really cool about these patients? Look for this as well. Sometimes in these patients who have obstructive lung disease, they have this little like coving that you can see sometimes within their graph. And that's because they have a kind of a reduction in their peak expiratory flow rate. And so sometimes you'll see this kind of reduction, this little coving in thing, and that's an important thing to be able to differentiate between obstructive and restrictive. So if you see the curve shifted to the left, with a very massive increase in residual volume and an increase in total lung capacity, you're looking at obstructive lung disease. Now, compare that to restrictive. For restrictive, here's our normal in black, and in blue, we're going to talk about restrictive. In this situation, what do we know about their volumes? We know the residual volume is decreased. We know that all of these are decreased, so therefore their total lung capacity is decreased. And we know their IRV and their ERV is decreased, and the tidal volume stays the same. But since both of these are decreased, we see their forced vital capacity decreases. Okay? Look at their curve. If I take a deep breath in with this blue line here, a deep breath in beyond normal tidal volume inhalation, and then I breathe out as much air as I can forcefully beyond tidal volume exhalation, then from here to here, from this point here to this point here is my forced vital capacity. So from here to here, this is my forced vital capacity. Look how small that son of a gun is in comparison to obstructive versus normal. That's a tiny forced vital capacity. And then look at this. Look how much, like I might even overshot it. I might have to go like right here. From here to here is their residual volume, the amount of air that remains in their lungs after a forced exhalation. Look at that. That's their tiny little residual volume. And then look, if I take the forced vital capacity and the residual volume and combine them, this is the total lung capacity. Look how tiny it is. So in a patient who has restrictive lung disease, if they show you the graph, what will you see the curve do? You'll see that the restrictive curve will shift to the right. So restrictive, the curve shifts to the right. Obstructive, the curve shifts to the left and maybe has a little coving in of the expiratory curve. That's what I want you to remember. The last thing that we have to talk about here. When you look at these graphs, the next thing that we can do is we can take and look at whenever they're forcefully taking in air and pushing out air. What we can do is we can look at very specifically the volume of air that they are exhaling. So they take a deep breath in. From the moment I begin exhaling until the moment that I stop exhaling, I'm going to monitor that volume. And that's going to be on the y-axis. On the x-axis is going to be the time that it takes for me to start exhaling until I stop exhaling. What I want to know is, what is the maximum volume of air that I can actually exhale during that entire breathing process? The maximum amount of air, which is at the peak point of the y. So on the y-axis, wherever I hit the top, the peak point, that is my forced vital capacity. That would be this point here, okay? At 1 second, let's say that somehow I breathed for, I don't know, 5 seconds. Okay, so during that 5-second period, that was the maximum volume that I could actually reach. That was my forced vital capacity. At 1 second in the expiration process, I want to know how much air I was able to forcefully exhale. We call this the forced expiratory volume of 1 second. What you need to be able to take from this, my friends, is this ratio where we actually say FEV1 over the FVC. This is a particular ratio that we're going to use. In this example, let's say that the amount of air that I could forcefully exhale in the first second was 4 liters. Then that's going to be 4 liters divided by the maximum amount of air that I could forcefully exhale throughout the entire time period. And let's say that that kind of curve goes around 5 liters-ish. So 5 liters. 4 divided by 5 is going to be about 0.8. Multiply that by 100, and I'm going to get 80%. That's about what the normal ratio is between FEV1 and FVC. What I need to be able to determine now is what would that look like in an obstructive and what would that look like in a restrictive lung disease. Let's take a look. In obstructive lung disease, what we notice here is in this red curve here is that the FVC can be reduced. There could be a reduction in FVC. We said that. It could be anywhere from normal to decreased. Okay, so we see that that is potentially reduced a little bit. So let's actually put a down arrow for the FVC. The FEV1 though, that's the worst situation here. Look at their FEV1 in comparison to this one. So here's their FEV1. Let's just I'm going to make up numbers. I'm going to say that in the normal patient, it was about 4 liters. In this patient, oh my gosh, this is terrible actually. This might be somewhere around like 2. So now this patient's FEV1 is approximately somewhere around 2 liters. What in the heck happened? I dropped their FEV1 significantly. So in patients who have obstructive lung diseases, their forced expiratory volume in 1 second is significantly reduced, whereas their FVC can be just normal to almost slightly reduced. If that's the case and I take into consideration this ratio, what will I get in comparison to 80%? If a normal FEV1 to FVC ratio was 4/5 liters, which was 80%, and I went from 2 and I dropped my FVC down, let's just say to 4 liters, I'm definitely going to be less than 80%. If that was the norm, if the norm was 80%, you can tell me that 2 liters and 4 liters, what would that give me? That would give me like 50%. So my FEV1 over FVC ratio was definitely less than 80%. That's what we see in obstructive lung diseases. Important to remember that. Very reduced FEV1 and mildly reduced or normal FVC. All right, so now let's talk about restrictive. Now, it's very interesting here, right? So again, we're gonna take the normal curve here. That's their FEV1 at 1 second. That's their forced vital capacity, right, for the normal patient. Now here's the patient who has a restricted lungs. Look what happens to their FEV1. It drops, but not a crazy amount, right, in comparison to the patient who has the normal one, or in comparison to, look at this. Look at the FEV1 here for the restricted and the obstructed lungs. Massive difference, right? So restrictive, not a crazy reduction in their FEV1. We'll just give it like 1 arrow down, okay? Their FVC, though, does actually reduce. And so in comparison here is about 5 liters. If I'm kind of like, this is about 4 liters, because that was their FEV1, that was about 4 liters. Here their FVC is about 5 liters. I'm gonna say it's like somewhere around like 3.5. All right, so I'm just kind of extrapolating. So their FVC definitely dropped, maybe like about 3.5 liters. And their FEV1, it's just mildly dropping even a little bit below that one. So let's just like extrapolate that to about 3 liters. If that's the case, their FVC definitely was the one that dropped. Remember, what did I tell you was the big factor here for the restrictive lung diseases? What happens with their FVC? Drops pretty significantly. So what I'm gonna do is, I'm gonna drop my FVC by 2 arrows. In obstructive, I drop my FEV1 by these multiple arrows. So now, if I were to just kind of extrapolate here that I had 3 divided by 3.5, that's definitely gonna be greater than 80%, or at least about same close to it. So maybe about like 86%. So in that situation here, what do I notice about my ratio? If I look here and my numerator is really small, but my denominator is even really small, what happens to the overall number? It's gonna be large because my denominator is really small. And so in this situation, theirs will be greater than or equal to 80%. So in patients who have normal lungs, what was theirs? About 80%. And the patient who has a restrictive lung disease, theirs is about greater than or equal to 80%. But for a patient who has obstructive lung diseases, theirs is less than 80%. Very important to be able to remember that. And the reason why theirs is less than 80% is because their FEV1 at 1 second is significantly reduced and their FVC is only mildly reduced or almost normal. And the patient who has restrictive lung disease, they have a mild decrease in their FEV1 at 1 second, but their FVC is the one that really drops. So their denominator drops. Even though both of them drop, their denominator drops even more, which allows for their overall number to still be high, at least greater than or equal to 80%. That's what I need you to remember about normal versus obstructive versus restrictive when it comes to the spirometry. To put this in a quick little algorithm, let's come down and talk about that. All right, so when we compare obstructive versus restrictive, we're looking at this ratio that we just talked about, the FEV at 1 second over the FVC. For a patient who has obstructive, what did we just say? Their FEV1 is very low. We know that. So because they have a very low FEV1 and a really mildly decreased or almost normal FVC, what do we expect the ratio to be? Less than 80%. So because of that, they'll be less than 80%. They'll have a decreased ratio. And a patient who has restrictive lung disease, which is the primary problematic issue here. Which one is it, FEV1 or FVC? The FVC is the primary one that's actually reduced. If the denominator is small and the numerator is only mildly small, what's going to happen to the overall number? It's going to be large. So theirs will be greater than or at least equal to 80%. That is the big differences. So when you're looking at a patient and you're given, here's their FEV1, here's their FVC, determine their ratio. If it's less than 80%, this is likely obstructive. And again, the primary problem with this is which one of those actual variables? The FEV of 1 second. versus restrictive, their primary problematic issue that causes them to be greater than or equal to 80% is they have a very low FVC. All right, great. Now that we've talked about that, there's a couple other things that we can do with these pulmonary function tests. We're going to talk about something called DLCO, we'll talk about some bronchodilator tests, and then we'll do some other additional tests as well. All right, guys, so now we're going to talk about is the next thing that we can do within pulmonary function tests. And so what we do is we can use something called the diffusion of carbon monoxide. And it's a really interesting type of test, and I think it's actually something that you should know, especially for your exam, especially when you're trying to differentiate certain obstructive lung diseases from one another. Now, what we do is we actually give a patient a tiny amount of carbon monoxide. And what we're trying to determine is how much of that carbon monoxide diffuses across their alveoli into the blood. And then we measure how much we give them versus how much we exhale. And the difference in between there is how much actually diffused into the blood. And that's what we're trying to determine. Now, the diffusion of the carbon monoxide is very dependent in the same way like oxygen CO2 is upon very specific factors. One is the total surface area. This is one really important one that I want you to know. So the total surface area by which the gases are supposed to be exchanged is very significant. It's directly proportional to the diffusion of carbon monoxide. The higher the total surface area is, the higher the amount of diffusion of carbon monoxide there is. The lower, the less diffusion. That's really important, especially for one of those diseases. Which one was it? Emphysema, that actually has a very low total surface area. What do you think that it does to the DLCO, the amount of carbon monoxide that would diffuse across this alveolus into the blood? Just think about it. Low total surface area, what would that do to the DLCO? It would decrease the DLCO. We don't see that in chronic bronchitis because there is no effect with chronic bronchitis on total surface area. This here is just a kind of like a constant. It's a coefficient. This here is the pressure gradient, and here's the thickness of the respiratory membrane. Thickness is really important when it comes to situations such as interstitial lung diseases. You know, interstitial lung diseases, they're part of restrictive lung diseases. They have very thick respiratory membranes. If they have very thick respiratory membranes, so let's imagine here that I added another class into this. Let's just say I added interstitial lung diseases into this class here. We already know that with emphysema, there is a decrease in the total surface area because of the destruction of the alveolar septal, the walls, the bronchial, elastic tissue, and so we know that they have a reduced DLCO. In interstitial lung disease, what happens to the thickness of the respiratory membrane? It increases. This is a type of restrictive lung disease. If the thickness increases, what will that do to the DLCO? It would decrease the DLCO. So DLCO may not be super beneficial in being able to differentiate restrictive versus obstructive lung diseases. But what we know is that this would have a decrease in the DLCO because it's inversely proportional to the DLCO. Now, if we compare emphysema to chronic bronchitis, there would be a difference there then. So we could say, oh, this patient more likely has emphysema because they have a reduced DLCO. Chronic bronchitis is a normal DLCO. What about asthma? This one's variable. And I just want to mention it because it is something that you may see on the exam and I don't want you to be too confused about. In patients with asthma, one of the theories is that because there is so intense bronchoconstriction and lots of bronchial edema, if they have intense bronchoconstriction and bronchial edema, what happens is they have air trapping, right? They have air trapping. So air is not able to exhaled out. So CO2 can't be exhaled out. And so because of that, their alveoli may become hyperinflated. If they're more hyperinflated, what happens to their total surface area? It may increase a little bit. If their total surface area increases a little bit, what may that do to the DLCO? It may increase the DLCO. So in patients with asthma, they may have a normal to slightly increased DLCO. So these are the things that I want you guys to understand. Okay, so that is an important concept. So I hope this makes sense when it comes to DLCO. So if you have a patient, you go through the pulmonary function test, you obtain their FEV1 or FVC ratio, and you say, oh, less than 80%, likely an obstructive. Which one is it? Is it asthma? Is it emphysema? Or is it chronic bronchitis? Well, how would I determine that? Maybe look at the DLCO. If the DLCO is low, it's likely emphysema. If it's normal, it could still be asthma or chronic bronchitis. And then if I really wanted to, in certain scenarios, in asthma, when they're really hyperinflated, it may be increased. And then for interstitial lung disease, It wouldn't really help us if we just did this on its own. We would have to say, oh, their FEV1 over FVC was greater than or equal to 80%. And then we checked a DLCO and it was low. That's more supportive of interstitial lung disease. Okay, now that we've covered that, the next thing that we can also do with the actual pulmonary function test is test the degree of reversibility. This is really cool. I'm confused if someone has COPD versus asthma. I don't really know. They have obstructive lung disease because their FEV1 over FVC ratio is less than 80%. I do the DLCO, doesn't really help me. So I'm trying to figure out, okay, what else could I do to really differentiate between these two? This is really cool. I can give the patient a bronchodilator. So I'm going to give them something called a beta agonist. And what this is going to do is it's going to open up the bronchioles by causing them to dilate. And what this will do is it'll open the airway up a little bit and make it easier for air to be exhaled. In patients who have asthma, there is a reversibility. That's one of the key things. It's reversible. In patients with COPD, it's relatively irreversible. So I'm going to give them a bronchodilator. And what I'm going to do is I'm going to measure their FEV1 prior to the bronchodilator and then post bronchodilator. And what I want to know is what happens. If I bronchodilate it, open up the airway more, it should be easier for air to be exhaled, theoretically, right? So what I want to do is I'm going to put post FEV1, post FEV1. What would I expect? I would expect an increase. I would expect an increase in the FEV1 for both of them. But here's where it gets a little tricky. You have to be greater than or equal to 12% increase in the FEV1 to be considered reversible, which is more indicative of asthma. If you don't reach greater than or equal to 12%, it is not likely a reversible type of disease, and it's more likely COPD. So if it is greater than, if it is increased but it's less than 12%, it's likely COPD. If it's increased post bronchodilator and it increases greater than or equal to 12%, it's more likely asthma. That's what I want you to remember. Okay, so we've gotten the pulmonary function test to determine if it's obstructive versus restrictive. We use the DLCO to maybe help us differentiate between emphysema and chronic bronchitis. We use the bronchodilator test to really help us to differentiate between asthma and COPD. And then what if we're really kind of confident that the patient has asthma, but they're not symptomatic? We want to really kind of see, is this patient really having asthma, but they haven't had an exacerbation lately? I can actually induce a patient who is non-symptomatic into having maybe a little exacerbation to test and see if they do have asthma. Because not only is asthma reversible, but it's inducible. I can actually cause them to have a hyper-responsiveness. So, you know, bronchial smooth muscle in normal patients, you give them methacholine, they'll bronchoconstrict a little bit, but nothing crazy. And a patient with asthma, they're gonna bronchoconstrict. And they'll do it very intensely. And if they bronchoconstrict, you're going to have them really, really narrow their lumen. Imagine how difficult it's going to be able to get CO2 out and exhale air through a very tiny lumen, more than normal. What would I expect to happen to my FEV1? So if I measured it before I gave the methacholine, and then I measure it after methacholine, I would expect what? A decrease in my FEV1 because I'm going to bronchoconstrict. If the decrease in the FEV1 is greater than or equal to 20%, that is indicative of bronchial hyperresponsiveness, which is supportive of asthma. Remember that. All right, the next thing that I want us to do is let's take a look here. Instead of us actually looking at kind of writing things down on the actual whiteboard of what a chest x-ray or CT would look like for a patient who has COPD or chronic bronchitis or emphysema or bronchiectasis, let's take a look at a couple images so that you guys can have more of a visual representation of what these actual images look like for patients with obstructive lung disease. All right, so let's go ahead and take a look at some images here. So the first one that I want you guys to take a look at here's a chest x-ray of a patient that definitely classifies as a COPD, or this is definitely pretty obvious. So what you'll see is you'll see some massive hyperinflation of the lungs, these really tall looking lungs. And this is like a PA chest x-ray. So if we were looking at it kind of in a posterior to anterior view, if we were to turn them into do a lateral view, their anterior posterior diameter would be massive. So again, you see these really tall hyperinflated lungs, and you see something called hyperlucency. So whenever you have air on the chest x-ray, it appears very dark. So look how much air is trapped in these lungs because they're very hyperlucent, they're very dark. That's one thing. So two things so far: hyperinflation. The second thing is very hyperlucent lungs, very dark on the chest x-ray. The other thing is, look at the diaphragm. There's supposed to be a right hemidiaphragm that bulges up and a left hemidiaphragm that's supposed to bulge up. The dang thing's flat. So I got a flat diaphragm. That's because there's so much hyperinflation, it's pushing the diaphragm down. The other thing that's really important here for these patients is, if you look, sometimes the ribs almost appear somewhat straight. That's not the most obvious sign, but whenever they're very hyperinflated, their ribs can kind of have almost a horizontal or straight-like appearance. So a big couple things to be able to remember for these classic, in this situation, COPD patients, more likely emphysema predominant, will have hyperinflation on the PA or AP chest x-ray. If you get a lateral, they'll have an increased AP diameter, like a barrel chest look. They'll have hyperlucency of their chest field due to a lot of air trapping. They'll have flat diaphragms, and on top of that, they may have these flat or almost horizontal appearing like ribs. All right, so that covers our COPD chest x-ray, likely emphysema predominant. All right, so we're taking a look here at a CT scan. And again, this is of a patient who has COPD. One of the really interesting things that you see out of this is, again, here's our right hemidiaphragm right here, and here's the left hemidiaphragm right here. So we have the heart in this position. What you're noticing, and this is all lung parenchyma, and you see how there's a line right here, and then it looks like a little septal tissue here, a little septal tissue here, a little septal tissue here. This is also parenchyma. It's just air-filled. And these air-filled sacs have become so enlarged because of alveolar wall destruction that they become these huge air sacs near the pleura. Do you remember what I told you happens in patients who have emphysema? They form these big things called bullae or blebs, and they have high risk of rupturing and then emptying air into the pleural cavity, which you can't really see here, which would cause a big pneumothorax. So this is not a pneumothorax, but it can lead to one because, again, this is an air-filled sac, just a really large one due to alveolar wall destruction in COPDers. And again, you can see some of these very, very large walls here. All right, that's our COPD, again, patient, but more particularly one of the complications such as bullae that we see in emphysema predominant patients. All right, so we're looking here at another CT scan, right hemidiaphragm, left hemidiaphragm, heart here in the center. And what you're looking at is you're seeing these, like, these are your bronchi. So these are actually like your bronchioles, and you can see them kind of extending out to the periphery. Now, if you notice something, look how huge they are. They should not be this obvious and this dilated. Whenever they have this very large dilated appearance to them, we see this in patients who have bronchiectasis. This is actually called what's called tram tracking, and they're just these big, huge, dilated bronchioles that you'll be able to see on a CT scan most predominantly. You may be able to see them on chest x-ray, but you'll definitely be able to pick these up on CT scan for bronchiectasis. All right, so the last image that I want you guys to take a look at is, again, here's another CT scan, right hemidiaphragm, left hemidiaphragm, here's the heart, and again, here's going to be the vertebrae. But what you're seeing here is, again, you see all lung parenchyma, but we're seeing the cut sections of the actual bronchi or bronchioles. You see how, first off, they're very dilated. But you know what else is really interesting in some of these, especially this one? You see how it's very dilated, and then it has like this little like nugget coming off of the edge of it. It almost takes on the appearance of a ring, but we call this a signet ring. So if you guys ever take a picture of a signet ring, it also looks like just this little big pearl on top of a normal kind of like ring. And so it's really, really interesting. We call this the signet ring sign. So you see one here. If we were to try to find another one potentially, we may be able to find one maybe right here. Here you're going to see the dilated bronchiole with, again, this like kind of little pearl thing coming off the edge. But this is a very common finding in bronchiectasis, these dilated bronchioles with these like little edges coming off here, which we call the signet ring sign. We see this in bronchiectasis. All right, that covers all the images for our obstructive lung diseases. Let's get back to the whiteboard. All right, so we've talked about chest x-ray and CT. The next thing that we also should talk about is sometimes it may be beneficial. Remember I told you, what is the complication of a patient who has chronic bronchitis? They may have something called cor pulmonale due to, again, intense pulmonary vasoconstriction due to Again, having less perfusion to the poorly ventilated alveoli and good perfusion to the well-ventilated alveoli. And because you may have poorly ventilated alveoli all over the lungs, you may have intense pulmonary vasoconstriction, put a lot of stress on the right heart and cause right heart failure. We may be able to pick that up on echo. So if we're doing an echo of a patient who has COPD, what you could be looking for is right ventricular hypertrophy or right heart failure secondary to cor pulmonale. And that may be helpful if you're thinking of a patient has this due to something like COPD, secondary to which one more likely? More likely due to chronic bronchitis. In comparison, more commonly than emphysema. Usually emphysema, we see this in the later stages. All right, my friends. The next thing we have to talk about is a couple other additional tests. They're not as high yield, but I want you to understand them. So let's come down and talk about CBC and ABG. All right, the next thing is with a CBC. If a patient has something like chronic bronchitis or they have bronchiectasis, in these situations, what I want you to remember again, more likely chronic bronchitis and maybe bronchiectasis. They have lots of mucus plugging and narrowing of the airways, which reduces ventilation to their alveoli. Because of that, they may have less oxygen reaching their actual bloodstream. What is that called when there's less oxygen in the blood? Hypoxemia. Hypoxemia chronically may stimulate your JG cells in the kidney to make something like, the proximal convoluted tubular cells, not JG cells, the proximal convoluted tubular cells to make something called erythropoietin. Erythropoietin will then stimulate your red bone marrow and say, hey, there's less oxygen. Maybe if we make more red blood cells, we can have more oxygen carrying capacity, and that may help. And so sometimes in patients with chronic bronchitis or bronchiectasis, you may see that they have an increased number of red blood cells, so they have an increase in their hemoglobin, and they have an increase in their hematocrit, which is called polycythemia. You may see that in these patients with COPD, primarily chronic bronchitis predominant or bronchiectasis. The last thing that I want to talk about is an arterial blood gas. I don't think this is as valuable as people may think, but it is something that you may be asked about on your exam. When a patient is having an exacerbation of their asthma or their COPD, it's important to be able to kind of think about this. If a patient's really breathing fast and very, very, very tachypnic because whatever the trigger may be for them, there was a trigger and they have a worsening of their COPD or they have a really severe episodic asthma attack. In those situations, they may breathe really fast because they may have hypoxemia, they may have hypercapnia, and so they're trying to compensate for that hypoxemia or hypercapnia by breathing really fast. So if I have a patient who has respiratory alkalosis, right, it would make sense. It's likely that they are having an increased respiratory rate. And the reason why is maybe they have a significant mucus plugging that's reducing oxygen getting into the airway, reducing the amount of oxygen getting into the blood, causing hypoxemia, less CO2 being able to be exhaled, so CO2 is building up in the blood. And then the response to this is to increase your respiratory rate. If you increase the respiratory rate, what happens as a result of this? You try to breathe faster to breathe off more CO2 and bring in more oxygen. If you breathe faster, you're going to exhale more CO2, theoretically. If you exhale more CO2, what is that going to do to the actual equation? You guys remember that equation? I know you guys do. CO2 plus water yields carbonic acid, which dissociates into protons and to bicarb. If a patient is exhaling lots and lots of their CO2, then this amount is decreasing, and so Le Chatelier's principle says you want to shift the reaction this way, to the left. And so what would happen is we would actually shift this reaction to the left. And what would that do to the number of protons? That would decrease the number of protons. If you have less protons inside of the bloodstream, what does that do to the pH? It increases the pH. And so as a result, we would have an increase in the pH. And so this would be called an alkalosis due to a respiratory problem where the patient is breathing really, really fast. We can see this in maybe exacerbation. So think about it. That's why sometimes ABGs may not be as helpful as your exam. If a patient's sitting in the room and breathing at a respiratory rate of 50 breaths per minute, you'll likely be able to know what their ABG is going to tell you. It's likely going to tell you that they probably have a very severe respiratory alkalosis. Their pH is going to be high and their CO2 is going to be low. And it may also show a hypoxemia, but we can also pick that up off the O2 saturation on their finger, right? So it's important to be able to consider these things. And this may not just be due to a mucus plugging in situations like bronchiectasis or chronic bronchitis. It also could be due to intense bronchoconstriction in situations such as asthma, okay? Now, the problem with this is that if a patient is breathing at very, very high respiratory rates for a long period of time, the concern is that this increased work of breathing will eventually lead to fatigue. And if this fatigue occurs, their diaphragm will not be able to maintain that respiratory rate. Their intercostal muscles will not be able to maintain that respiratory rate, and they'll start to fatigue. And if they fatigue, their respiratory rate will start to drop. Their ability to clear CO2 will start to drop. And then their ability to bring in oxygen will start to drop. And they can actually develop worsening hypoxemia. They can develop a respiratory acidosis. That leads us into the next part here. What is a concerning finding sometimes for patients is if their respiratory rate is decreasing. And this could be because of fatigue. They've been in situations now where they're having to compensate for so darn long that now they can't get CO2 out. You know what this is also really scary of? If I have a patient who has intense bronchoconstriction, and I'm having a difficult time being able to get CO2 out of the actual bloodstream into the alveoli and then exhaled in situations such as asthma. In early asthma, if it's not as intense of a bronchoconstriction, they may still be able to get CO2 out of the lungs mildly and bring a little bit of oxygen into the blood, right? In severe asthma, I'm talking very, very severe asthma, where the bronchoconstriction is so intense, or they've been working so hard to breathe for so long that their muscles are starting to get fatigued and they can't generate the same rate to clear CO2. Either way, one of the problems, we're not getting CO2 out. CO2 is going to start building into the bloodstream. If CO2 builds up into the bloodstream and we have an increase in CO2, what does that do to this equation? Well, then we would have high CO2. We would want to shift the reaction in the opposite direction, which would increase the number of protons. We know this equation, right? That if we have, again, CO2 plus water yields carbonic acid, which breaks down into protons and bicarb, we know that we're going to have an increased amount of CO2 because we're not clearing it. We're either not clearing it because of a severe obstruction blocking CO2 out, or because the respiratory rate is so low because we're fatigued, because we've been working so hard. So they've been doing this for so long, their muscles become weak and they can't do this anymore. And they start slowing down. CO2 starts accumulating, or they have a massive obstruction that's not letting CO2 get out. If that happens, the CO2 builds up. And what happens? We know that if Le Chatelier's principle says that if this side of the reaction is increased, we have to shift it to the side where there's less. And so this will shift the reaction to the right and increase the amount of protons. If we increase the amount of protons, what does that do to the pH? It decreases the pH. And if we decrease the pH, then we now have a acidosis. This is a problematic issue, right? And so this is why it's very, very important to understand. If a patient has severe asthma and their pH is actually starting to show signs of acidosis and CO2 retention, you better be scared, because this means that their patient is either fatiguing out and they're not able to continue to breathe at the rate that they've been to compensate, or their obstruction is so severe that they're not getting CO2 out. In the same way, if a patient has a COPD exacerbation, they could have been breathing so hard for a long period of time to compensate, but again, they're starting to tucker out. This could also be a particular reason. There's one more thing to think about. You know, patients with COPD, chronic COPDers, they naturally have a chronic respiratory acidosis. But the way that they don't actually have to breathe the way that they do is that they compensate from their kidneys. Their kidneys actually retain bicarb and excrete protons. And so they naturally help to be able to compensate for their actual low pH by retaining bicarb. And so that's one of the important things, is that patients with chronic COPD may have a degree of respiratory acidosis. They may have a high CO2, but their pH will be stone cold normal. And the reason why is they've retained bicarb from their kidneys over a long period of time. So it's important to remember, just because someone has a respiratory acidosis does not mean that it's actually an acute problem, like an exacerbation, like they're starting to fatigue out from breathing so hard, they have a severe obstruction. It could be that a patient has a chronic respiratory acidosis because they've had chronic COPD for a long time and they naturally have a high CO2. and that's kind of dropped their pH a little bit, but they accumulated bicarb and excreted protons and then helped to be able to bring their pH back up to normalize. So again, it's important to think about these things. That's why I think sometimes the physical exam is a lot easier to follow and more important to follow than an ABG, because these can vary. But either way, I hope this part made sense. We've covered diagnostics. We're moving on to the last part here of our obstructive lung disease lecture. Let's talk about treatment. All right, so let's talk about the treatment of obstructive lung disease. We'll start first with COPD, then we'll talk about asthma, and then we'll finish up with bronchiectasis. So first things first, for these disorders, what I want you guys to understand is we're gonna have a specific way that we're treating them. One of the big things for COPD is that they have a lot of bronchospasm, so bronchoconstriction. What we should try to do is obviously do the opposite of that, bronchodilate. If we bronchodilate, we open up the airway more, allowing for more airflow in and out of the lungs. That's going to help these patients. So, primarily with symptoms. It will not reduce the overall chance of mortality or death, but it will help to be able to potentially reduce the morbidity, the symptoms, the probable issues that they have with this disease. So how can we do that? Let's understand basically the pharmacology behind it. So here we have the bronchial smooth muscle. What we want to do is dilate to increase airflow in and out of the lungs. So when we zoom in on one of these smooth muscle cells, on these smooth muscle cells you have beta 2 receptors and muscarinic type 3 receptors. Now, basic concept here is that whenever you have a beta 2 receptor, whenever you stimulate this beta 2 receptor, it'll naturally cause bronchodilation. Whenever you act on what's called a muscarinic receptor or an M3 receptor, and where acetylcholine would bind onto that, it'll actually produce bronchoconstriction. So we want mainly bronchodilation. So I want to give a drug that will potentially act as an agonist and stimulate this receptor to be able to increase bronchodilation. And I want to give another drug category that'll act as an antagonist and inhibit this receptor and help to be able to decrease bronchoconstriction. So decrease bronchoconstriction. So if I inhibit this receptor, I'll inhibit the bronchoconstriction and decrease the activity there. And therefore, if I decrease bronchoconstriction, I may allow for a little bit of bronchodilation. So I need to give muscarinic antagonist and beta adrenergic receptor agonists. You know the best way to be able to deliver this drug to the smooth muscle? Inhaled. So I'm going to give inhaled bronchodilators in the form of beta 2 receptor agonists, which is going to promote bronchodilation. We can give it short acting, and this would generally be in acute scenarios. So whenever a patient maybe is having an acute COPD exacerbation, I can give them a drug like albuterol. In more of a long-acting, so long-term chronic management of the patient who has COPD, I can give them more of a longer-acting beta-2 agonist, and this would be something like salmeterol, formoterol, vilanterol, all of these different types of drugs, okay? But the basic concept is they'll produce bronchodilation. Long-acting, just remember, it's salmeterol, formoterol, vilanterol, and the main one to remember for the short-acting is albuterol. Okay, these will bronchodilate. The other drug category is the M3 receptor antagonist. They're going to inhibit this receptor, prevent bronchoconstriction, and therefore cause bronchodilation. The drugs that I could give is short-acting or long-acting. The short-acting would obviously be during acute exacerbations of their COPD, whereas the long-acting is for more of the chronic management of these patients. You know what actually is really interesting? I can give a combination of the short-acting beta agonist and a combination of the short-acting muscarinic antagonist and a combination during acute COPD exacerbations. So what we write these as we can do a short-acting beta agonist plus a short-acting muscarinic antagonist. Short-acting muscarinic antagonist. These are actually a common thing that we can give, and we call this a duo-neb. And a duo-neb is a combination of a albuterol and a SAMA, short-acting muscarinic antagonist. The most common one to remember is ipratropium bromide. So this is a very common duo-neb combo that we give to patients during their acute exacerbations. Now, in long-acting, this would be more of the chronic treatment of the COPD. We could give a muscarinic antagonist, and that would be tiotropium. So remember these things. So bronchodilators, we can give beta agonist, muscarinic antagonist. You can give short-acting as a combo, duo-neb during acute exacerbations, and then long-term, you can do a LABA, a long-acting beta agonist like salmeterol, formoterol, vilanterol, or a long-acting muscarinic antagonist, a LAMA, like tiotropium. All right, beautiful. That covers that part. The next thing that we also want to consider here for these patients is that sometimes these patients are at high risk for pneumonia, especially chronic bronchitis, right? So because chronic bronchitis is definitely at high risk for pneumonia, what we may be able to do is give a very specific drug that may reduce inflammation and prevent exacerbations of COPD, causing high risk of pneumonia. What is that actual drug? Azithromycin. Azithromycin has been shown that it can be one antibiotic that you could give to patients, okay, especially if they have lots of exacerbations. If they had at least 3+ exacerbations, then you should consider giving them something like azithromycin to prevent further exacerbations and things like pneumonia, okay? That's an important thing to consider. The other thing that's really important for these patients is something called oxygen therapy, giving them oxygen. Not all COPD patients are candidates for oxygen therapy, meaning that they have to wear oxygen like 16 liters a day. I mean, 16 hours a day. They may have to get a couple liters, 2 to 3 liters, about 16+ hours a day. And those patients, what are the category? What is the actual patient population that would be qualified for that long-term oxygen therapy every day? Well, one of the particular reasons here would be that they have some issue where during rest, during exercise, whenever, if their SpO2 is less than 88%, or the amount of oxygen that makes it into the alveoli crosses the actual capillaries, crosses the alveolar membrane, across the capillary membrane and gets into the blood. The PaO2 is less than 55 millimeters of mercury. In this situation, they would qualify for oxygen. If a patient, again, has an SpO2 of less than 88% or a PaO2 of less than 55 millimeters of mercury during rest, during exercise, they qualify for long-term oxygen. The other situation where you may be a little bit more stingy and say, you know what, I actually would accept even a higher oxygen target that they would need it, because less than 80% is actually pretty low, right? And when you consider this in a normal human being. We would be even a little bit more likely to say, hey, man, I'd even have a lower threshold for other patients to start oxygen therapy because they're at higher risk. And patients who have already right heart failure due to cor pulmonale, long-term COPD, or they have an increase in their number of red blood cells, so they have polycythemia. That tells me that they've had hypoxemia for a long period of time and they're at high risk for further hypoxemia. So what I need to do for these patients is treat them a little bit earlier. So maybe they don't make 88%, but in these patients, they're at less than 90%. If they reach less than 90%, or the amount of oxygen that reaches their alveoli and crosses into the pulmonary capillary blood, so the PaO2, the partial pressure of arterial oxygen, is less than 60 millimeters of mercury. So you see how the goal, you have to be a lot lower in this category who does not have right heart failure, does not have polycythemia. You have to have a way lower oxygen saturation and a lower PaO2 to start oxygen. In this category, you can have a higher oxygen saturation, a higher PaO2, but you also have to have right heart failure or polycythemia to be a candidate for oxygen therapy. So remember that. Again, one more time. Less than 88%, PaO2 less than 55, no right heart failure, no polycythemia, candidate for oxygen therapy. Patient SpO2 less than 90% or PaO2 less than 60, have right heart failure or polycythemia, oxygen candidate. All right, now that we've talked about bronchodilation, antibiotics, oxygen therapy, the next thing I really want you to understand is, out of these three that I've just mentioned, which one of these have actually been shown to reduce mortality in patients with COPD? Only one of these, oxygen therapy. So I want you to remember that oxygen therapy is one of those types of treatments that actually do have the ability to reduce mortality. Okay, let's come down and talk about the other ways that we can treat COPD. All right, so the next thing we have to talk about with COPD is that we can actually reduce some of the inflammation. Remember I told you that there is a chronic degree of inflammation. Remember that process? Let's see if you guys do remember. We have the tobacco smoke, or the pollutants, whatever it may be, triggers the macrophages. Macrophages release leukotrienes. They also can release maybe some degree of prostaglandins. They can also release certain types of interleukins like interleukin 8 that can attract in neutrophils. But what we know is that these leukotrienes and prostaglandins, that they may work to be able to cause bronchoconstriction. They may also ramp up and amp the inflammation, which may cause some degree of increased mucus secretion, so a little bit more mucus that's produced. All of these things that we understand, right? On top of that, neutrophils are also going to be coming into the area, and they start releasing things like reactive oxygen species. They start releasing proteases, And this starts causing an increase in the inflammation, right? Starts destroying some of the elastic tissue within inside of the actual bronchial walls, increases the mucus production even more. And then on top of that, if these epithelial cells are damaged from repeated exposure to the tobacco smoke, they'll activate fibroblasts that will cause fibrosis. What if I had a drug that would potentially be able to inhibit the macrophages from releasing some of these cytokines and saying, hey, macrophages, shut up. Don't release all of these cytokines. That's going to cause this massive inflammatory response, causing bronchospasm, elastic tissue reduction, increased mucus, and fibrosis. That would be a pretty cool thing, right? So guess what? These are where corticosteroids come into play. Corticosteroids basically help to be able to shut off something called the arachidonic acid pathway. Without going crazy into detail, you guys need to know that arachidonic acid is the precursor to making things like leukotrienes, making things like prostaglandins, which are kind of like the alert molecules that are released by the macrophages to tell that there's inflammation going on, telling the neutrophils to come to the area. If we inhibit the actual arachidonic acid pathway, we would actually reduce leukotrienes, reduce prostaglandins, and all these other cytokines that kind of trigger the inflammatory response, and maybe reduce bronchospasm, reduce mucus production, and potentially reduce fibrosis. Wouldn't that actually be relatively helpful? And maybe even reduce some of the actual further breakdown of the elastic tissue as well. This is actually a pretty beneficial concept. So inhaled corticosteroids, things like budesonide or fluticasone, we would generally use them in combination with a bronchodilator. But more specifically, since this is more of a chronic management, we've used this more specifically with a LABA, so a long-acting beta agonist, or a LAMA, a long-acting muscarinic antagonist. So very important. Now, in patients who have very severe, acute, exacerbated COPD, so they're having a COPD exacerbation, an acute exacerbation, maybe the inhaled corticosteroids will not be enough. And in those situations, we may want to give them PO. We want to give them systemic corticosteroids, very high levels of anti-inflammatory mediation. And we would use IV or PO steroids, more likely IV, especially if you're having a patient having difficulty breathing. Probably going to be difficult for them to swallow a pill. We'd likely give them IV methylprednisolone, or if they can tolerate a pill, PO prednisone, to be able to really increase the corticosteroid levels to really try to shut down the inflammatory response. So we would use this in an acute COPD exacerbation. All right, my friends, that would cover this component. Now, the next thing that I want us to talk about is preventing infections. These patients with COPD, especially which one? Chronic bronchitis, especially patients with chronic bronchitis, because of the mucus that's accumulating within those airways, it can cause a colonization of bacteria, increasing the risk for pneumonia. So now imagine that the patient is already at high risk for pneumonia and you have them being exposed to the most common types of factors that cause pneumonia, a Streptococcus pneumonia or a influenza, so Haemophilus influenza virus. So if they are exposed to, influenza virus, or they're exposed to Streptococcus pneumonia, which are two common microbial agents that can lead to pneumonia in a patient who's already high risk for pneumonia, this can definitely increase the mortality for these patients. So because of this, they're already at high risk for pneumonia, these patients with chronic bronchitis. Now, if they get infected by Streptococcus pneumonia or influenza, this will definitely increase the mortality rate, because what it'll do is it'll definitely increase the risk of pneumonia, worsen their pneumonia, and increase mortality from the pneumonia. So what we want to do is make sure that these patients get vaccinated against these very common pathogens, such as the pneumococcal vaccine, protecting them against Streptococcus pneumonia, and the influenza vaccine, protecting them against influenza. Because influenza, not only does that actually cause a really nasty pneumonia, but it also can increase the risk of patients developing a pneumonia due to Staphylococcus aureus. Remember, influenza definitely increased the risk of Staphylococcus aureus infections, especially in the elderly. So think about this, okay? Now, this is a very important thing. If I give these patients vaccines, I can potentially reduce their mortality. So it's important to be able to give this very important instruction to your patients, because this has a mortality benefiting effect. The next thing, what if I remove the dang cause of the patient's trigger? The trigger was the tobacco smoke, which activated our macrophages, which activated the neutrophils and caused all this inflammatory mediators, which caused bronchospasm, caused destruction of the elastic tissue, increased mucus production, caused fibrosis. The dang tobacco was the primary cause. What if I get rid of that? Wouldn't that prevent the further progression of the disease and therefore help to be able to maybe reduce mortality of the patient? Abso-stinkin-lutely. So smoking cessation will definitely be a factor that you want to try to push your patients to follow because it can reduce mortality. So whenever you're telling a patient, here's what I want you to do for their COPD, the things that you need to consider that actually have mortality benefits: smoking cessation, making sure they're vaccinated against the pneumococcal bacteria and influenza, and if they need oxygen therapy, make sure they get the oxygen therapy if they fit the category that we talked about above. The last thing that I want to talk about is more specifically for the acute exacerbation of COPD. So someone has an acute COPD exacerbation. In that situation, sometimes these patients really, we need to work to eliminate their CO2 and just provide them kind of a ventilatory support. So really what we could actually find benefit from in these patients that actually can reduce mortality in these acute exacerbations of COPD is putting them on something called positive pressure ventilation. And this would generally be BiPAP. So BiPAP has been shown to be able to reduce mortality in these exacerbating situations. And if they fail BiPAP, then we would perform endotracheal tube intubation, and then we would mechanically ventilate them invasively. Okay, but we don't want to have to do that generally. We would try to do what kind of things? If a patient has an acute exacerbation of their COPD, give them a bronchodilator, the short-acting ones, in the combination of a duoneb. Give them IV steroids, right? On top of that, if they have any need because they have a pneumonia that caused this, treat the underlying pneumonia. And then on top of that, also provide good ventilation support, particularly BiPAP. If they fail BiPAP, then you can consider something such as endotracheal tube intubation. Okay, we talked about the treatment of COPD. Let's now move on to asthma. All right, guys, so let's talk about the treatment of asthma. So asthma is relatively similar to COPD. We're gonna try to bronchodilate, reduce inflammation, give some ventilatory support, and then we'll talk about the stepwise regimen in chronic asthma management. If a patient has asthma, it's the same exact thing that we talked about before. We don't really use the muscarinic antagonist as much. You can consider it. There's nothing wrong with it. It's just it's easier to be able to keep it separate on your minds for COPD. But in a patient who has asthma, they're going to benefit more particularly from the beta-2 receptor agonists. If you guys remember, we want to promote bronchodilation. So we want to be able to have agonists that stimulate the beta-2 receptors to be able to increase the bronchodilation response, to open up the airways, get more air in and out. The other concept here is that smooth muscle has calcium channels on them. We can give a particular drug that actually will bind around these calcium channels and block calcium from being able to get in. So they inhibit calcium entry, and if calcium comes into the smooth muscle cell, it activates the cross bridge, activates the whole troponin, tropomyosin type of process, and leads to contraction. In this situation, we block calcium entry. Therefore, we block the actual smooth muscle contraction. Therefore, we block bronchoconstriction. Therefore, we decrease bronchoconstriction and maybe promote bronchodilation. So there's two drugs that I want you guys to remember. The ones that stimulate the beta-2 receptors are called the beta agonists. We've already talked about these, the short-acting ones. In acute scenarios, or maybe a patient is having like an acute exacerbation or they're having a little asthma episode, we can give them albuterol in like a nebulizer or potentially even an inhaler. And long-acting would maybe be more of the chronic management in these patients. Okay, and again, remember, albuterol is the short-acting beta agonist. The SABA, salmeterol, formoterol, vilanterol, those are more of the actual long-term beta agonists, more for the chronic management. And I'll teach you guys the stepwise fashion of how to know how to add a SABA, then which one do I add next, then when do I add a LABA, etc. I'll explain all that in the stepwise fashion. The other situation is magnesium. Magnesium is going to act like a little calcium channel blocker on the smooth muscles. If magnesium blocks these calcium channels, it prevents calcium entry and prevents bronchoconstriction, which will allow for bronchodilation. So magnesium in an IV bolus form is great during acute exacerbations of asthma. So sometimes if patients have coming in, they're having a really bad asthma exacerbation, we can give them a short-acting beta agonist like albuterol and IV magnesium to really get a good bronchodilation response and help to be able to open up the airways to allow for more CO2 to come out, more oxygen to come in. Really great concept there. All right, now, the other concept is, remember the pathophysiology. One of the reasons that patients have asthma is really intense bronchoconstriction. The second is that they have lots of inflammation and edema. What if I had a way of being able to reduce some of the inflammation and reduce some of the bronchial edema and reduce some of the bronchoconstriction even more? Let's talk about that now. All right, so remember the pathophys, guys. You have some type of trigger, whether it's an allergen, so pollen, dander, dust, right? Or again, you can think about the patients who have high risk of allergic types of reactions by the atopic triad, atopic dermatitis, allergic rhinitis, and asthma. Or the non-allergic causes, viral URTI, some type of beta blocker, cold, air, exercise, GERD, or again, we even talked about the Samter's triad. So patients who have nasal polyps and asthma, you should be very careful with giving them aspirin. Now, if they're exposed to this particular trigger, we already know that it gets taken up by the dendritic cells. So it gets phagocytosed by the dendritic cells. When it gets phagocytosed by the dendritic cells, it'll actually take a piece of it and expose it on its MHC2 complex. When it exposes on the MHC2 complex, it activates the T cells. The T cells will start to release cytokines like interleukin 4 and interleukin 5. We know that interleukin 4 more specifically stimulates plasma cells. Plasma cells will make antibodies. Do you guys remember what kind of antibodies it makes? The more specific one is IgE antibodies. The IgE antibodies will bind onto the mast cells. And then when the actual specific trigger binds onto the IgE antibodies connected to the mast cells, which have these like little things here, you see these like little green dots, these are called granules. What are these little things here called? They're called granules. Once they're stimulated by the allergen binding onto the IgE antibody, it causes these granules to undergo degranulation, meaning that they just basically fuse with the membrane and release all of their contents. What are some of the things that they release? They release things such as leukotrienes, prostaglandins, histamines. And what do these things do? They cause vasodilation of the actual capillaries in the bronchial walls, causing increased leakage of fluid, which causes edema. They also cause bronchoconstriction. So they cause the smooth muscle constriction. And that is an important concept because now what I can do is I can target specific steps in this pathophysiological process. Remember why I talked about it so dang much? This is why. What if I gave a drug that acts like a monoclonal antibody and just blocks up? So you're exposed to the particular trigger, you have this response where you release cytokines, and then you make antibodies, but I give you a drug called omalizumab, which is a monoclonal antibody. And it binds up these IgEs so that they can't bind onto the mast cells. So then they can't degranulate, release these cytokines, cause bronchoconstriction, bronchial edema. That's pretty cool. Who would I give this to? Mainly those patients with allergic rhinitis or atopic dermatitis or very refractory allergic asthma. So it's more for the allergic type of asthma or very severe end stage like stage 6 or stage 5 asthma. Okay? Now that one doesn't actually be the one that you want to target. Let's say I target the degranulation step. You know when I take the granules, they're stimulated by the allergen, binds to the IgE antibody, tries to come and stimulate these granules to degranulate. What if I gave a drug that stabilized the mast cell membrane and prevented these granules from releasing these molecules like leukotrienes, prostaglandins, histamines that cause the vasodilation, increased capillary permeability, edema, and bronchoconstriction? That'd be a great drug. This is where we can use things like chromalin sodium, which is a mast cell stabilizer. And the primary indication is for prophylaxis against exercise-induced asthma. So we can give mast cell stabilizers, which prevent degranulation of these cytokines in exercise-induced asthma. Omalizumab to block the IgE antibodies in allergic asthma or severe refractory asthma. The next situation is corticosteroids. We already talked about this a little bit. Remember that in order to make things like leukotrienes and prostaglandins, what do I need? I need something called arachidonic acid. And arachidonic acid will be acted on by different enzymes like the COX enzymes and the lipooxygenase enzymes to be able to make different types of molecules like prostaglandins or leukotrienes. If I give corticosteroids, they help to be able to inhibit this arachidonic acid pathway. And so then I don't stimulate the COX enzymes, the lipooxygenase enzymes, and I decrease my prostaglandins, I decrease the leukotrienes, I decrease the vasodilation, increase capillary permeability, and I decrease the bronchoconstriction. That's a really interesting process. And so for corticosteroids, we're trying to be able to inhibit the cytokine release from the mast cells by inhibiting the arachidonic acid pathway that occurs in them. We can use these in two forms, the inhaled form. What do you think we use this in? More of the chronic states. And we use it in the same way we use in COPD. We use it with a LABA. But we don't use LAMAs too much, or muscarinic antagonists, in asthma. That's primarily for COPD. So whenever you give someone an inhaled corticosteroid, it has to be used with a long-acting beta agonist, which is a bronchodilator. We can also give it IV or PO in the same situation we would give it during COPD. When was that? When a patient is maybe a little bit sicker, and in those situations we need to increase the levels of the corticosteroids to really maintain a good anti-inflammatory effect. We would use that in acute exacerbations of asthma. So if someone's having an acute asthma attack, we would use IV preferably, because if a patient's breathing really fast, you think they're going to be able to take a tablet, it's going to be very difficult. So I give them a big slug of IV methylprednisolone. If somehow they can tolerate PO prednisone, you could also consider that. But that's what we would do in very severe acute asthma attacks. All right, the next thing is if we didn't target the antibodies that kind of trigger the mast cells, we didn't inhibit the granules from being able to release these cytokines. We didn't inhibit the actual arachidonic acid pathway that makes these particular molecules. What if I inhibit the receptor which leukotriene is supposed to be able to bind to? So this is a leukotriene receptor where it's supposed to bind onto the smooth muscle of the bronchioles or the capillaries that are in the bronchial walls and promote edema and bronchoconstriction. If I give a drug, it'll inhibit these particular receptors. If I give corticosteroids, it'll inhibit the arachidonic acid pathway. If I give mast cell stabilizers, it'll inhibit degranulation. If I give omalizumab, it'll inhibit the Ig antibody from fusing with the mast cells. So if I give these leukotriene receptor antagonists like montelukast, it'll block the leukotrienes from being able to bind to these particular receptors, inhibit vasodilation and increase capillary permeability, inhibit bronchoconstriction, allow for bronchodilation and less bronchial edema. Who do I use this in? I use this in aspirin-induced asthma and exercise-induced asthma. So exercise-induced asthma prophylaxis is, which one? You guys remember? Mast cell stabilizers. Treatment in aspirin-induced asthma and exercise-induced asthma is leukotriene receptor antagonists. Omalizumab in allergic asthma, in the situations like allergic rhinitis, atopic dermatitis, or severe refractory allergic asthma. And then corticosteroids you can use inhaled in asthma at any stage particularly. But again, usually it's used with a LABA in asthma that's more chronic. And then we use this more as an IV PO version in very acute asthma attacks. Okay, we talked about the ways we can reduce inflammation. Now let's talk about what do we do with a patient that we've started them on bronchodilators, we've given them anti-inflammatory agents. So a patient that comes in with an acute asthma attack, they're breathing really fast, they look terribly, they look like they collapse at any moment. You started a short-acting beta agonist, so you gave them albuterol inhalers, you gave them IV magnesium, you gave them IV steroids. Now you're moving on to the next step, which is trying to improve their ventilation. How do we do that? Let's talk about that now. All right, so we have a patient who has an acute asthma exacerbation. We start them on a short-acting bronchodilator like albuterol, all right? So we would like nebulized. We give them IV magnesium. We give them an IV steroid like maybe methylprednisolone. If they somehow tolerate PO, prednisone would be another option. And again, it's not saying that you can't give them a short-acting muscarinic antagonist like ipratropium. It's easier to be able to delineate this in your head that you would do it more likely for COPD, but you can give muscarinic antagonists in asthma. It's just more commonly remembered and easier to remember for your COPDers. So we started them on that, but they're still really like having shortness of breath. They're still dyspneic. They're still working really hard to breathe. What else can we do to ease their work of breathing? We can do positive pressure ventilation. So in these patients, we can do positive pressure ventilation, and one of those things, just like we did in a patient who has COPD, would be BiPAP, bi-level positive airway pressure. This is going to help to be able to exhale the CO2 and generate enough pressure to push air into the airways. So I think this is a really great tool. And if the patients fail, they aren't able to tolerate BiPAP, they fail BiPAP, they're continuing to get worse, you can then transition them into an endotracheal tube intubation and then subsequently mechanically ventilate them that way, which would likely require a decent degree of sedation for these patients. All right, we've talked about the treatment of asthma, but one of the big things that I think is really important is how to be able to stepwise approach these patients. So you have a patient outpatient-wise that you're managing, and they're starting from the beginning. They have mild asthma. what is the treatment that you would start with? And as their asthma, let's say, progressively gets worse from mild to moderate to severe to maybe refractory, what kind of agents am I adding on in sequence or modifying in sequence? Because you may get a question on this. So you have a patient whose first one, very mild. You're gonna start them on a short-acting beta agonist, and it's just PRN. So you only do this PRN. So whenever they're having little kind of like wheezing episodes, shortness of breath, maybe a tight chest, take a hit, a couple puffs of your albuterol and see if that provides improvement. If it does, you can stop there. If the patient comes back and says, hey, I'm still doing my albuterol, I'm using it a lot, and I'm still not getting any better. I'm still having wheezing, I'm still having shortness of breath, I'm still having some tightness in my chest, what can I do now? Then the next thing we can do is we can escalate up the treatment and we can add something on. What we would add on next is we would add on a very low dose inhaled corticosteroid. So we would start off, you can still have a SABA, use that during your exacerbations, but every day I want you to take a low dose of an inhaled corticosteroid, which are going to represent as a down arrow, inhaled corticosteroid. If the patient continues to get worse despite that, then what you can do is say, okay, you're coming in, you've been using your albuterol when you need to? Yeah. You've been taking your inhaled corticosteroid, the low dose every day? Yep. Okay, now what we're gonna do is keep doing that SABA whenever you're having symptoms, but what we're gonna do is we're gonna add on a long-acting beta agonist. So now we're gonna add on formoterol, salmeterol, vilanterol to your actual daily regimen. So now you're gonna still have a low-dose inhaled corticosteroid, but we're gonna add on a long-acting beta agonist to that, okay? Then from there, patient comes in and says, hey, I'm still getting worse, I'm still having these problems. You're still using your SABA, yep. You're still using your low-dose inhaled corticosteroid in your LABA, yeah. Okay, up the dose of your inhaled corticosteroid to a medium dose and keep doing the LABA every day. So then we're gonna go to a medium dose inhaled corticosteroid and we're gonna keep using the LABA. Patient comes in and says, hey, I'm still having worsening symptoms. Okay, dang it. All right, let's increase the dose of the inhaled corticosteroid, keep the LABA, and keep using your SABA as needed. So then we're gonna go high dose inhaled corticosteroids and we're gonna keep the LABA. Patient comes in and they're saying, hey man, I've done everything you asked me to do and I'm still having these worse wheezing and shortness of breath and difficulty being able to breathe, this tight chest. What do I do? Okay, what we're gonna do is we're gonna keep the inhaled corticosteroid at high dose. We're gonna keep the LABA, but I'm gonna add in an oral steroid. And they should be able to tolerate this oral steroid because in these patients, they shouldn't have such an acute asthma exacerbation where they can't actually even breathe or speak in between sentences. If you have a patient who's having difficulty being able to speak in full sentences, that's an acute asthma exacerbation. And from there, we're gonna do something like an IV steroid. Again, short-acting beta agonist, magnesium, and again, trying things like ventilation support. Now, if a patient goes through all of these, in step 5 and in step 6, we may consider an additional thing that we can add on, especially if the patient has allergic asthma. If they have allergic asthma, in step 5 and step 6, you can add on something called omalizumab, because this can be used in severe refractory asthma as well as asthma which has some type of allergic component to it. So in step 5 and in step 6, you can add omalizumab onto these patients if they're having refractory asthma or even better, features of allergic asthma, okay? All right, I hope that made sense for asthma. We talked about the treatment of asthma. We got one more obstructive disease to talk about, and then we'll get into some cases. Let's talk about bronchiectasis. All right, so let's talk finally about the treatment of bronchiectasis. Okay, so when we have a patient with bronchiectasis, what's the primary issue? The primary problem that I wanted you guys to remember is that the mucus. There's excessive amounts of mucus that they have. Very productive, very foul smelling, blocking up the airways. So one of the most important or easiest ways to remember these is gonna be mucolytics, and we'll talk about that. But the other problem is that they have bronchospasm, right? So they have some degree of bronchospasm, so we'll talk about ways that we can bronchodilate, reducing the bronchoconstriction. But I want you guys to remember what was the primary trigger. So obviously for asthma, we avoid the particular triggers, the pollen, the animal dust or dander, the particular types of things that may trigger an exacerbation of an atopic dermatitis, allergic rhinitis, or an allergic asthma exacerbation, staying away from getting viral URTIs, not running in the cold, maybe trying to improve our GERD, staying away from beta blockers, staying away from aspirin, etc. For COPD, not smoking. Those are the things that we can avoid. For patients who have bronchiectasis, it's trying to treat the underlying disease. And what was one of those that I told you was really important? Cystic fibrosis. Unfortunately, you can't reverse that. You can try to be able to manage the symptoms, which is what we're going to try to do when they have bronchiectasis, managing the symptoms. For other situations like primary ciliary dyskinesia or Cardiganer syndrome, again, there's nothing we can do about that. We can't reverse that. It's already happened. It's a mutation. For other situations like things that we can potentially fix, like if you have a tumor that's protruding into the lumen of the bronchi, you might be able to remove that tumor. If you have a foreign body, you might be able to remove that foreign body. If you have an extraluminal tumor that's compressing, like a lymph node tumor compressing on there, maybe you can remove that. And that will allow for mucus to be able to be expectorated and prevent it from building up. Right? If it's chronic inflammatory situations like allergic bronchopulmonary aspergillosis, treat it with antifungals. If it's a systemic inflammatory disease, put them on steroids or DMARDs to improve that disease. So treating the underlying disease is definitely the thing that's going to prevent the further worsening and progression of the disease. But it has to be something that can be potentially treated or reversed. After we've done that, then we talk about ways that we can help to be able to reduce bronchospasm. It's straightforward. It's everything that we talked about before. Same thing for COPD. What do you want to do? We want to give drugs that antagonize the M3 receptor, which helps to decrease the bronchoconstriction. We want to give agonists that stimulate the B2 receptors, beta 2 receptors that actually help to bronchodilate. It's the same concept. If it's short acting, you would give albuterol. If it's long acting, it's salmeterol, formoterol, verlanterol, okay? If you want to be able to work short acting and block the M3 receptor, it would be ipratropium. If you want long acting, it would be tiotropium. Very straightforward. The whole point is to bronchodilate, reducing the bronchospasm in these patients. The next thing that I want you guys to understand is that these patients have very high risk of infections. These bronchi are getting so clogged up with mucus that it creates an opportunity, a nidus, for bacteria not to be able to be moved through those bronchi and be expectorated. And so it accumulates, and then leads to a nasty infection. And so these patients are at very, very high risk for pneumonia. And so what do we do to be able to reduce their risk for even further exacerbations of pneumonia and therefore leading to high mortality rates? Well, one of the things that we can try to be able to do is make sure that we maybe give them vaccines that prevent further chances of having infections due to the most common pathogens that are bacterial and viral. Same thing we would do for COPD. Make sure that they get their pneumococcal vaccine so that they don't develop a pneumococcal pneumonia. And then also make sure that they get their influenza vaccine to make sure that they don't get some type of pneumonia due to influenza. Remember, influenza, especially in elderly patients, increase the risk of Staphylococcus aureus pneumonia. So this is an important thing. And then because they're at high risk of pneumonia, what did I tell you was the primary pathogen was the scary pathogen, especially in cystic fibrosis patients. They have very high risk of pneumonia secondary to Pseudomonas. So you have to be able to consider that when you're giving them antibiotics, it has to be antibiotics that are guided towards Pseudomonas. And if you're unsure about the particular pathogen, what would be a way that you could test for the pathogen that could be causing the pneumonia? Maybe consider plus or minus some sputum cultures to be able to test for what type of pathogen it is. After you start them on a more broad agent, you can narrow it down to whatever the pathogen may be. But on your vignettes, clinical vignettes that you're going to see on your exam, it's most likely going to be Pseudomonas. So remember the antibiotics that you can use to treat Pseudomonas. Okay, the next thing that we'll talk about is called hemoptysis. So with hemoptysis, coughing up of blood, in these particular patients, why does this happen? Remember I told you it's because they have so much inflammation that's eroding through the thin bronchial walls that it just chews into the bronchial blood vessels and causes then blood to actually enter into the lumen of the bronchus. And then they cough up that blood. Well, what if I had an ability to either resect out the disease section? So what if I could actually take and resect out this disease section? That could be one particular way. So I could do a very specific type of lung resection of the most diseased portion of this patient who has bronchiectasis. Or what I could do is I could take a catheter find the bronchial vessels that are actually being eroded into and the ones that are feeding into the lumen of this bronchus, and I could embolize it. And if I embolize it, I prevent further blood from being able to enter into this lumen, and I stop the actual hemoptysis. This is called bronchial artery embolization. Bronchial artery embolization. And these are some of the things that we can do to these patients here. So again, what I want you to remember is the same kind of concept here. Treat the underlying cause, give bronchodilators to reduce bronchospasm, prevent further infections by giving the vaccines and treating their potential exacerbations or high risk of pneumonia. What's the big pathogen to not forget? Pseudomonas aeruginosa. And again, prevent kind of episodes of hemoptysis such as bronchial artery embolization or resection of the massive disease segment in these patients with bronchiectasis. What else? What was the big thing I told you for these patients? They're high mucus production. We can give them drugs that'll break up that mucus and make it easier to expectorate, preventing that chronic inflammation. Let's talk about that. All right, so for mucolytics for these patients, it's basically the whole design is to be able to break up the mucus and make it easier for the patient to expectorate. Remember, they got thick mucus, right? Whether it be due to the cilia being problematic, whether it be due to thick mucus due to cystic fibrosis, whether it's because you have some type of obstruction of the airway, or whether it be due to chronic inflammation. Regardless of the cause, we need to be able to make sure that we provide good hydration to the patient. If we hydrate the patient, we might be able to push more water into these actual secretions. And if you increase the water in the secretions, it may thin them out a little bit and help to be able to make it easier to cough them and move them along so that they're not obstructing the airway. The other thing is chest PT. So this could be due to like many different ways. One, it could be vest therapy. So sometimes they put this vest around the patient and just have it like beat the patient's chest a little bit to be able to kind of help to expectorate or break up some of the actual mucus secretions. You can literally like turn the patient on their actual stomach and then kind of hit their back a little bit. Any way that helps to be able to kind of move, like postural drainage, maybe laying in a particular position, giving some hits and beats onto the chest can help to be able to move some of those secretions and break them up and make them easier to be able to cough up. The other ways we can give nebulizing medications. So one of them is called N-acetylcysteine. N-acetylcysteine is a really interesting drug that basically helps to be able to break up certain types of bonds that are in the mucus that make the mucus strong. It helps to be able to break up some of the disulfide bonds and all those things that make the mucus really tough and thick. And by doing that, it thins the mucus out a little bit. And the other one is we can give hypertonic saline nebs. So 3% hypertonic saline nebs. And what this does, it helps to be able to kind of draw fluid into the secretions as well, thin them out and make them easier to expectorate. So these are things to remember for the mucolytic function. 1, hydrate. 2, physiotherapy. Maybe that's someone beating on the back of someone's chest and having them lean forward to allow for postural drainage, or putting like a vest on them that kind of like beats their chest continuously for a certain amount of time to break up some of those actual secretions and make it easier to expectorate, and give them nebulizer treatments of things like N-acetylcysteine, which breaks up disulfide bonds within the actual mucus, making it thinner, easier to expectorate, or 3% hypertonic saline nebs, which pulls fluid into the actual mucus and helps to be able to thin the mucus out, making it easier to expectorate. All right. The last thing is that sometimes in these patients, unfortunately, really, really sad, their lungs are really damaged. They have lots of mucus, and usually this is in patients with cystic fibrosis, that there is a high chance that they may need a lung transplant. So in patients with bronchiectasis secondary to cystic fibrosis, there is a very strong chance that these patients will not be able to prevent the progression of the disease and have a high likelihood that they'll require a complete lung transplant. All right, my friends, we did it. Even though this took a massive amount of time and I'm so exhausted, we did a really good job by covering all of this information. But believe it or not, we're not done. We got to get to the cases. We got to really understand this stuff even more. So head on over and let's do some cases on obstructive lung diseases. All right, fam, we're going to go ahead and do some cases now on some obstructive lung diseases. Let's see if we can all come together and really understand this topic now. So we got first case, 75-year-old male presents to the engineering clinic with dyspnea, so shortness of breath, and his usual productive cough that he's had for about more than 3 months for the past 2 years consecutively. That's a very high clinical pearl there. What does that kind of like lead me to think? COPD, but which one more predominantly? More likely chronic bronchitis predominant. All right, past medical history, hypertension, tobacco use. Tobacco use is going to be one of the most common causes for patients with COPD, like chronic bronchitis and emphysema. Okay, cool. Physical exam, we go to examine the patient, and what do we appreciate? Well, first thing is when we go and we actually use our stethoscope, we listen, we hear some inspiratory rhonchi. So whenever they're taking a breath in, we hear kind of like a snoring respiration kind of within their airways, and then we ask them to cough and it kind of disappears. During expiration, we hear some wheezing. That's one thing, okay? So inspiratory rhonchi, wheezing. So the inspiratory rhonchi is probably telling me, and the expiratory wheezing is telling me that there's some kind of like mucus that's accumulating within the airway, or some type of narrowing of the airway that's obstructing the airflow in and out. They have abdominal obesity, so they're a little bit puffy. They also have some JVD, pedal edema, and hepatomegaly. What did I tell you on the whiteboard? That those three things plus abdominal obesity due to the diaphragm hyperinflation, pushing the diaphragm down, kind of pushing the abdominal contents forward, giving this patient that puffish type of look. What does this usually signify? Those blue bloaters due to right side heart failure, right? So cor pulmonale. So this is kind of showing me cor pulmonale, hyperinflation, pushing the diaphragm down to give them that abdominal obesity look. Okay. Definitely, again, more supportive of chronic bronchitis because you don't see cor pulmonale too often in emphysema until it's in the late severe stages. Vital signs, hypoxic, right? So 86%, they're definitely hypoxic at rest without any kind of like supportive supplemental oxygen on them. Respiratory rate's 26, so just a little bit tachypnic. Heart rate's 104, so they're slightly tachycardic, and then blood pressure is just, just a teensy bit below the actual elevated point of 140. So I'd say with that being said, main vital concerning signs is hypoxemia, mild tachypnea, and a slight tachycardia. Okay. Let's move on to the next thing. So given tobacco use, which obstructive disease do you really suspect out of all of these? So again, we got to go back. Is it asthma? Is this bronchiectasis, or is this some type of like COPD where it's chronic bronchitis or emphysema, or kind of like a mixture of the two? It's sometimes really difficult to be able to kind of point out that kind of like mixture. Oftentimes they do coexist, but we're trying to be able to separate them to some degree. And I don't think it's asthma. And the reason why is that this patient's relatively older. Asthma can present in older individuals, but commonly you're going to see it in younger individuals. And usually they don't have this like productive cough for 3 months out of the 2 years. It's usually episodic, right? So I don't think it's that one. Bronchiectasis, it could be. They do have a productive cough. It could be that. It's hard to say, but I don't, think that it's necessarily the case, because usually what I told you guys to think about is it's usually that purulent, foul-smelling type of cough that they have with a nasty-smelling sputum. I didn't really mention that there, so it still could be that, but I'm kind of leaning more to like a COPD. And between these, I think it's more of a blue bloater type of appearance, chronic bronchitis than emphysema. So we could say it could be chronic bronchitis, could be bronchiectasis. Maybe we need a little bit more information to really parse out which one of those is. But I definitely think it's more likely a COPD than a bronchiectasis kind of patient. Okay, and again, bronchiectasis. Remember, you got to think about those causes. Could it be a tumor? Could it be a foreign body? Could it be primary ciliary dyskinesia or cystic fibrosis? Usually you'll see those a little bit in the younger ages. Or is it kind of like a chronic inflammation of the airway or systemic inflammation? So I do definitely think this is more supportive of COPD, chronic bronchitis predominant, but we can still think possibly bronchiectasis. All right, let's move forward. Again, we kind of like really put together this really interesting concept that whenever they have that really high pulmonary artery pressure due to the intense vasoconstriction of the pulmonary vessels, due to multiple alveoli kind of being hyperinflated or not actually being utilized during ventilation, they can get this intense pulmonary vasoconstriction because maybe the alveoli are plugged up, or they're not actually ventilating the alveoli properly because there's lots of mucus plugs and bronchoconstriction. So either way, those ventilation to the alveoli is poor, and so you want to decrease the perfusion of those alveoli, so you cause pulmonary artery vasoconstriction. That increases the pressure in the pulmonary arteries, puts a lot of stress on the right heart. Right heart failure ensues, and then they develop JVD, hepatomegaly, and pitting or pedal edema. All right. Boom. Roasted with that one. All right, next thing here is when we talk about these patients, other complications that they're definitely at risk for besides cor pulmonale, chronic bronchitis wise, is they're at high risk of pneumonia, right? We said that if you kind of have these mucus that's accumulating within the bronchioles, all of the mucus, that mucus that's blocking up the bronchioles, you're supposed to be able to clear bacteria, right, through those bronchioles up via the cilia. Well, if you have this big kind of like occlusion or obstruction within the airway, you're not going to be able to get that bacteria cleared from the bronchioles. And so what happens is they can get locked up in these small little alveoli and bronchial areas and lead to an infection, and that can lead to pneumonia. The other thing is, because these patients do develop pretty good hypoxemia, that hypoxemia over time, if it's chronic, will tell the actual kidneys to start pumping out something called erythropoietin. And erythropoietin will tell your bone marrow to pump out more red blood cells. So the other thing I would see is if I did a CBC, I might see some increase in their hemoglobin, increase in their hematocrit, increase in their red blood cells, so-called polycythemia. All right, well, if we really want to diagnose this patient with a COPD and differentiate them from from bronchiectasis, things that I would really would want to know is, okay, let's do some PFTs. PFTs would be great because it'll also help me to really discern if this is restrictive versus obstructive, especially if the picture's a little bit confusing. So when I do the PFTs, my patient has a low FEV1 and a relatively low FVC. So when we put the ratio between these, the FEV1 is more significantly decreased, so it drops the percent ratio to less than 70%. We know that whenever the FEV1 over FVC is low, less than 70, some books will say less than 80%, it's more suggestive of an obstructive, where if it's normal or high, it's restrictive. So automatically I know that it's obstructive. Plus, I can also see that the residual volume is really high and total lung capacity is high, so they're likely having a hyperinflated lung due to an obstructive cause. Well, the next thing I can do is I can actually check the DLCO. This determines the diffusion capacity across the alveoli. This can be somewhat helpful in discerning, is this some type of, emphysema, or is it asthma, or is it COPD, is it chronic bronchitis? So generally, I know that it's obstructive, right? When I have a DLCO that is decreased, usually it could be suggestive of one specific type of COPD. You guys remember? Emphysema, they have such a decreased alveolar surface area that it really drops the DLCO. Because remember, surface area is directly proportional to the DLCO. So if you actually cause a decrease in the total lung surface area, you'll decrease their DLCO. Whereas in asthma, they might have hyperinflation and a slightly increased or moderately increased DLCO. And sometimes that can actually increase, a small to moderately increased surface area, which may increase their DLCO. So you can actually see a normal to slightly increased DLCO in asthma. But again, I think that in this patient's population here, we see a decreased DLCO. So we may see that this might be kind of like an emphysema or some type of, chronic bronchitis type of case. But again, usually decreased DLCO could be suggestive of COPD. But if you're really looking to be more specific, it's the emphysema predominant in that case. All right, but here's the real interesting test that we can do. We can give the patient a bronchodilator. When we give them a bronchodilator, what this will do is tell us the degree of reversibility. So remember, asthma is reversible to bronchodilators, so you can actually get their smooth muscle to relax a little bit, dilate, open up the airway, and improve their expiratory volume. So if it's COPD, though, that's relatively irreversible. The damage is done. Their smooth muscle is not really going to react very well and then dilate enough to increase their expiratory volume significantly. So what we do is we do a bronchodilator test after we've done this PFTs and then look at what happens to the FEV1, their expiratory volume, within the first second. If it increases greater than 12%, it suggests a reversibility like asthma. If it doesn't, it suggests more of an irreversible type of COPD picture. All right, so this is, again, supportive of more of a COPD rather than asthma picture. CBC, again, did show polycythemia, supportive of more of that chronic bronchitis type of picture. The echo supported more of a right ventricular hypertrophy, which, again, suggestive more of the cor pulmonale, which is in the chronic bronchitis feature. Now, again, ABGs aren't super helpful in these patients because oftentimes you can look at their exam and determine that, but it can be somewhat helpful if you're concerned about a CO2 narcosis or the patient being in an exacerbation of some type and they're super obstructed and they're just not clearing their CO2 and their level of mental status is declining significantly. But sometimes in this patient, it's pretty obvious they were breathing relatively fast. So I would expect that they're probably going to have some degree of like a respiratory alkalosis. But here's the thing, they may always breathe fast. So in these patients, it's likely that they have a chronic respiratory acidosis. In COPDers, it's usually a chronic respiratory acidosis, and they likely always have a compensatory response, which is for their kidneys to be able to respond to that. So if you're acidotic, you're going to want to be able to reabsorb bicarb and excrete protons. And so you would expect that their bicarb would go up to compensate for the high CO2. So oftentimes these patients are usually chronic respiratory acidosis with metabolic compensation. All right, so how do I start my treatment process for these patients? Well, you got to address the issues for these patients with COPD. One is you obviously have the patient to address the bronchospasm. There's a lot of inflammation within the airways, and this inflammation definitely causes a lot of bronchospasm. So one thing I can do is start bronchodilators. In the acute situations, I can do short-acting ones. So things like albuterol and ipratropium, usually as a duaneb combo. Or I can do long-term outpatient management with a long-acting one. So something like salmeterol, formoterol, vilanterol, or a LAMA, which is a muscarinic antagonist, and that would be something like tiotropium. The next thing I'd want to do is reduce the inflammation. So sometimes these patients may benefit from inhaled corticosteroids, especially in use with a LABA or a LAMA. And if they're really having an exacerbation and really having a difficult time breathing and clearing out their CO2, we can consider things like steroids, PO if they're able to tolerate it, IV more likely if it's a severe exacerbation to really reduce that inflammation. But there's three particular things that I really think are really important to remember for these patients because they have been shown to reduce mortality. Smoking cessation, obviously one of the primary things here is that this patient is a tobacco user. So because of that, it increases their risk of worsening damage. If you get them to stop, you can at least prevent somewhat of the progression of the disease. Oxygen therapy is key. Remember, SpO2 less than 90%, they have cor pulmonale, and they have polycythemia. In this situation, you start them on oxygen therapy, maybe 2 to 3 liters for about a good chunk of the day, 15 to 16 hours in the day that they're going to be on O2. So again, a very, very, very important concept here. And again, if they don't have cor pulmonale or polycythemia, then it's less than 88% SpO2 or less than 55 on their ABG. And then the other thing is vaccination. Vaccination is the only other one that also against influenza and particularly the pneumococcal vaccination that reduces the mortality from pneumonia. So these would be the big things to not forget. All right, let's move on to our second case. 18-year-old female presents to the engineer clinic with dyspnea, difficulty speaking, and full sentences, dry cough, and a very tight chest. They have a past medical history, very particular for pet dander allergy with a recent viral upper respiratory tract infection and some exposure to a dog. That's probably where they got that dander allergy. So because of that, I'm thinking that this is more asthma, just because they're younger, they're presenting with an episodic type of appearance where they have dyspnea, difficulty speaking in full sentences, so it's likely an asthma exacerbation, a dry cough, and a very tight chest. A tight chest is a very concerning sign for asthma. Plus, here's their triggers. Think about their triggers. It's either allergic, so some type of allergy to something, pet dander, maybe some type of pollen, again, a lot of different things of that nature, drugs, whatever it may be. And then again, think about the atopic triad as well. So think about those patients with allergic rhinitis, atopic dermatitis, and asthma as well. The other thing is that what's the big triggers that are non-allergic would be viral upper respiratory tract infections, so some type of cold air, exercise, GERD, beta blockers, things of that nature. So I think that this patient, and then remember, don't forget Samter's triad, which is that triad of nasal polyps, aspirin sensitivity, and asthma. But I think this definitely seems like asthma. Well, let's go ahead and take a look here at their exam. When we look at their exam, we definitely see that they have wheezing when we're auscultating the chest, especially during exhalation. We see a lot of nasal flaring, really trying to be able to have accessory muscle use, so neck muscles, abdominal muscles to help them to be able to breathe. So we see an increased work of breathing, plus they're having difficulty speaking in full sentences. So I definitely see a very degree of respiratory distress due to them having to work really hard to augment their breathing. Vital signs, SpO2 is they're hypoxic, so 82% at rest with no oxygen on them. And then respiratory rate is 36, so they're tachypnic. They're really, really working hard to breathe right now. Heart rate's 144, so they're tachycardic, and then their blood pressure on inspiration is 88/46, and during expiration it was noted to be 108/52, which is relatively interesting because there is a degree of phenomenon there, which, if you guys remember, what is that called? Whenever your blood pressure drops more than 10 millimeters of mercury during the inspiratory process, it is pulsus paradoxus, and that's a common feature of asthma. So definitely seems like asthma, my friends. Okay, so given off of these things, the allergen exposure, the viral upper respiratory tract infection, and their history and physical exam, I think it's more suggestive of asthma. Okay, what are the other causes of asthma? Do you guys remember what they are? We said allergens, we said cold air, we said exercise, we said GERD, we said beta blockers, we said Samter's triad. Again, we went through all of that already. So how do we go about diagnosing a patient with asthma? Well, right now we can obviously tell that they look like they're having an asthma exacerbation. So PFTs may not be the best situation here. But let's say that in a perfect world that this patient came in and we were able to somehow get PFTs on this patient. If we did, we would see the same thing that we just saw in the COPD picture, that they would have a low FEV1 over FVC. We see a drop in their FEV1, we see a drop in their FVC ratios less than 70%, and we see an increase in the residual volume and total lung capacity. Oftentimes, something that we do in an emergent situation is we do something called a peak expiratory flow rate. We'll use a peak flow, and we'll look for their peak expiratory flow rate to be very, very low in these patients. So that might be something that you do at bedside. And in really these rough situations, they won't be able to exhale a lot of air. If you were to be able to get this patient to do a DLCO kind of testing, you would see that it could be normal to a slightly increased DLCO, whereas if it's decreased, it could be a more suggestive of COPD. But which one more predominant? Emphysema more predominant. Here's the best thing, though, to also consider. If you were to give this patient a bronchodilator like albuterol and then measure their PFTs afterward, you would notice that they are reversible, that they have a massive increase in their expiratory volume after getting a bronchodilator that actually increases their FEV1 to greater than 12%, whereas in COPD, it did not increase greater than 12%. So that's a big thing to remember. So sometimes what we'll do is if the patient, you're not usually in an exacerbation doing this, you're doing a peak flow. So you have them take this little apparatus, take them, have a deep breath in, and then breathe out into the peak flow, and it'll generate a volume. And then you'll estimate that based upon age, gender, a lot of kind of standardized things. Based upon that, you'll give them a bronchodilator, and then after the bronchodilator, you should expect that their expiratory volume within the first second should increase. And so then what you'll do is you'll have them come back and then take another blow at that peak flow and see if it improves, and you'll check the volume changes. And so usually in those patients, you would expect that their peak flow would be low, peak expiratory flow rate will be low. After the bronchodilator, you'll expect an increase in their peak expiratory flow rate. Now, if the patient did not have any symptoms, they came in and that they had prior episodic situations and that they came in outpatient, you wanted to test them to see, do they have a degree of inducibility? Can I provoke the bronchi, smooth muscle, to really bronchoconstrict in response to a particular medication more than normal people would? And so what we do is we do something called a methacholine challenge test. We give them this drug called methacholine, which is a cholinergic agonist. So it'll bind onto the muscarinic receptors and cause bronchoconstriction. And so if it causes bronchoconstriction, in a normal person, it wouldn't cause that much difficulty in breathing. But in a patient with asthma, they're very hyper-responsive, and so they respond to it and they intensely bronchoconstrict, that it drops their forced expiratory volume more than 20% after that test. And so that's a really, really big one to remember, to induce a bronchospasm. And again, in these patients, what will the ABG show? I would likely say that this patient is working so hard to breathe that if I were to look at it, it's probably respiratory alkalosis. They're breathing so hard, they're clearing off their CO2, that it's just causing their CO2 in the blood to drop. Okay. A question that I think would be important to answer is that what if the patient stopped really moving a lot of air? Their obstruction continued to get worse, that the ability that their chest became silent, and they weren't able to exhale air out of their actual chest. Then CO2 is going to build, and they'll start having a respiratory acidosis. That would be a really concerning one. All right, tell me that they're either fatiguing out or that they're obstructing their airway almost completely. So how would I start this patient off? Well, acutely, we're going to start off with bronchodilator, SABA. So again, albuterol is going to be the big thing. Give them IV magnesium because that'll also bronchodilate the area as well. IV steroids because they can't even speak in full sentences. There's unlikely that they're going to be able to tolerate taking a PO med. And then put them on BiPAP. BiPAP would be a great thing to be able to kind of really help with clearing some of that CO2, generating higher pressure within the airways to help to reduce the patient's work of breathing. So this would be the best thing to do. And if they fail BiPAP, you can intubate them with endotracheal tube intubation. But for managing these patients outpatient-wise, I think it's important to know this stepwise fashion. So you start off with, kind of this basic kind of regimen here where a patient comes in, you start off with a SABA. Okay, they're continuing to get worse, add on an inhaled corticosteroid at low dose. Oh, they're continuing to get worse, add on a medium dose inhaled corticosteroid, and then maybe add on a LABA. They're still getting worse. Okay, then, you can increase their dose of the inhaled corticosteroid and then add on a LABA. You can increase their dose of the inhaled corticosteroid, add on a LABA, increase their dose of inhaled corticosteroid, add on an oral corticosteroid, and then again, continue with the LABA. So I think it's important to remember that stepwise fashion for a patient, that as they continue to get worse and you've tried things, so a patient comes in, they start off, I'm having shortness of breath, some wheezing. Okay, start off with an albuterol. Every time you need it, use it. Okay, I'm still using it a lot, I'm not getting any better. Add on an inhaled corticosteroid, so budesonide with fluticasone, something of that nature. Then, okay, I've used that, doesn't work. Okay, well then add on a LABA. Okay, that didn't work. Okay, increase the dose of the inhaled corticosteroid. That didn't work. Increase the dose of the inhaled corticosteroid. Oh, that didn't work. Add on an oral steroid. Oh, okay, that actually did work. So those are the things to be able to consider, and it's important to be able to make sure that you either increase in a stepwise fashion to get them to the point of where they're having good response, and then if possible, if they're on the highest type of step here, see if you can step down to reduce the amount of medication load that they're on possibly. Okay, so these are big things to think about. Now, to make it easier for all these other kind of like alternatives, usually the best situation that you may be asked on the exam is which medication is best for exercise-induced asthma or aspirin-induced asthma that you can consider as an alternative throughout these situations. And the best answer would be your Montelukast, okay? The other one would be which one would be best for prophylaxis against those who have exercise-induced asthma? And you would say cromolyn sodium. Okay, and then the only other one that I would actually add on here is that if a patient has severe allergic asthma or refractory asthma, then you can consider omalizumab, okay? But severe allergic asthma that is refractory to a lot of these therapies, you can add on omalizumab. All right, beautiful. So the next case here, and the last case, is we have a 39-year-old male who presents to an engineer clinic with severe dyspnea, mild cough, past medical history of non-alcoholic cirrhosis. Actually, this is not the last case. We got another one after this one. All right, so interesting patient here. They're young, and they have a very severe dyspnea, mild cough, and a past medical history of cirrhosis, not due to alcoholism. They actually couldn't find an etiology for it. When we look at this patient, they have a very interesting type of appearance. They have a barrel chest, very thin, cachectic appearing type of look. They also have decreased breath sounds on their bilateral chest walls whenever you're trying to auscultate. And then they have expiratory wheezing. Okay, very interesting. Vital signs, not very hypoxic at rest. Slightly, very slightly tachypnic. Heart rate's 84, so normal, and blood pressure is pretty normal. Okay, nothing crazy there after physical exam other than just kind of what looks like more of a pink puffer type of appearance. Wouldn't you agree? When you have those patients who are pursed lip type of breathing, they're very thin cachectic appearing, they have barrel chest look, they have decreased breath sounds. Definitely more suggestive. But here's one of the interesting things. With patients who have that emphysema type of look, you usually see it in those who are smokers and really old. This patient's really young. So what did I tell you to think about in a patient who's less than 45 years of age, has an underlying liver disease, and really no tobacco use? They may have tobacco use. It doesn't necessarily mean that it can't also be smoking, but given the patient maybe has really no tobacco use, they do have liver disease, they have less than 45 years of age, and now it looks like they have like an underlying COPD. What did I tell you to think about? Alpha-1 antitrypsin deficiency, right, for the COPD cause. So I really think that this is emphysema, but I think it's alpha-1 antitrypsin deficiency. So whenever you think about that, you think about something very interesting. Which part of the lungs is most affected in patients with alpha-1 antitrypsin deficiency who present with this emphysema type of appearance? It's panlobular, so that affects more likely the bases of the lungs. So I'd see that more in the bases of their lungs that I would see these emphysematous changes as compared to those who smoke, which would be more at the apex, is a upper lobe predilection, right? With that centrilobular emphysema. All right. Very interesting. And then what is a very important complication that I want you guys to remember from emphysema, because they can get all these like bullae, these like very like large kind of like alveolar, kind of like a bronchiolar, kind of like really dilated look of a lung parenchyma. They're very high risk for popping and causing a pneumothorax. So don't forget that as well. All right, so when we go through diagnostics, we don't need to do this. We've already understood that this is an obstructive disease. It should be a low FEV1 over FVC, okay? DLCO, it's likely going to be decreased, especially this one, okay? More likely emphysema predominant, you're going to see a decreased DLCO. Not so much in chronic bronchitis. Post-bronchodilator, we know that they're not going to reverse. It's going to be less than 12%. What will the ABG show? Likely a chronic respiratory acidosis with metabolic compensation. Same thing for COPDers. Now, if we were to do like a chest x-ray or a CT scan of this patient, you would definitely see that this patient would have very like hyperinflated lungs. You would see some bullae and the emphysematous changes that would be involving more of the bases of the lungs. And how else would we test this patient? Send off what particular enzymatic test? The alpha-1 antitrypsin deficiency. So you would check to see if there's alpha-1 antitrypsin kind of mutation there present. How would I treat this patient? Just as you treated the patient who had the chronic bronchitis. So if it's an exacerbation, SAMAs or SABAs. If it's long-term, LAMA-LABA. Inhale corticosteroid if it's an exacerbation, IV or PO. Tell them to stop smoking. Tell them to use oxygen if they meet the particular requirements. Less than 88% for this patient, plus or less than 55 millimeters of mercury off their ABG. Okay, they don't have cor pulmonale, they don't have polycythemia, so we wouldn't go with the lower target like less than 90% or less than 60 ABG. And then make sure they're vaccinated, because smoking cessation, oxygen, and vaccination are the things that lower mortality. All right. Last case, 12-year-old male presents to the Ninja clinic with dyspnea, productive cough with foul-smelling sputum, has a medical history of cystic fibrosis, likely bronchiectasis. That's how they're going to present in this exam. So whenever you go ahead and examine the patient, they do have nail clubbing, they have some inspiratory rhonchi and expiratory wheezing, lots of mucus that are kind of obstructing the air flowing in and air flowing out, slightly hypoxic at room air at rest, they're slightly tachypnic, normal heart rate, normal blood pressure. What should we think, given the cystic fibrosis, which obstructive disease do you think it is? It is bronchiectasis. So what are some of the other causes of bronchiectasis? Remember, I told you if the cilia ain't working, it would be primary ciliary dyskinesia. If it was some type of like situation where they weren't actually making a very thin mucus, the mucus was super, super thick due to the chloride channels being altered, not pushing chloride into the mucus, not pulling water into the mucus, that would be cystic fibrosis. If there's something obstructing the movement of mucus, that could be a tumor or foreign body, or if there's just a massive inflammation of the airway due to it being systemic, like RASLE, or a fungus within the airway, like allergic bronchopulmonary aspergillus, that would be the causes. What other organs does cystic fibrosis usually affect? Which ones did I tell you guys to think about? Meconium ileus, pancreatic insufficiency, and some degree of patients who have instability, particularly males, okay? Or infertility, I apologize. The two complications that I wanted you guys to remember in bronchiectasis is that because the mucus is really chalked up within those airways and it causes so much inflammation, and it can start causing bronchodilation, and just the inflammation can wear and wear and wear through the airways, where it erodes into the nearby bronchial blood vessels and can lead to hemoptysis. The second thing is that all that mucus chalks up the airway and blocks bacteria from being cleared from that mucus area, just distal to that kind of mucus plug. And so it creates a nidus for infection, so pneumonia would also be a very important complication as well. How do you treat patients who have hemoptysis? What do you do? Bronchial artery embolization, or resect the really diseased segment out. All right, diagnostics, it's the same, my fam. We have a low FEV1 over FVC ratio. It's the same thing with every obstructive lung disease. The DLCO is going to be normal, okay? What will the chest CT show? This is the real big thing. If you look at these patients, you're going to see very dilated bronchioles. So you see kind of like that. You'll see like this really large, thick, dilated bronchiole in this view called the tram track sign. So these are big things to be able to consider. So just looking at these, again, highlighting it, there's your kind of tram track lines. The other thing is you may see these signet rings, which are like the dilated bronchioles with like a nearby like pulmonary vessel off the edge of it. So those are big things to think about for these patients. How do I treat them? Well, think about it. Start with the most important thing, treating the underlying cause. What's the underlying cause? Cystic fibrosis. You can't really reverse that. The only way to be able to stop this is to get a lung transplant. And then supportive care is going to be the big thing. So help to dilate those bronchioles that are really kind of inflamed and hyperspastic and undergoing bronchospasm with bronchodilators. Mucolytics to really help to clear some of that mucus from the airways to prevent hemoptysis, to prevent pneumonia and other complications. So hydrating them, keeping the mucus kind of like thin. Chest PT, so kind of beating on the chest, postural drainage, things of that nature to clear up some of that. Vest therapy, all of those things. And then sometimes nebulizers that'll help to really thin up the mucus, making it easier to cough up. So 3% hypertonic saline solutions or nebulized N-acetylcysteine, which really helps to break down some of the disulfide bonds in the mucus. And then a big thing is to prevent them from developing infections, so vaccinating them against pneumococcus and against influenza. And then remember, if these patients do develop pneumonia, which they are at very high risk for, you need to give them antibiotics that'll cover Pseudomonas aeruginosa. That's a big high-yield fact. All right, my friends, next thing that we'll do is we'll talk about restrictive lung diseases on another lecture. Get there, go check it out, and then we'll go over some cases of restrictive lung disease. Ninjas, I hope that this made sense. I hope that you guys enjoyed it, and as always, until next time.